Right. Is everyone here? Okay, shall we turn on some cameras? Turn your cameras on. Let's start today's class. Okay, so welcome to the second session on ischemic strokes, right? So yesterday we have talked about the core concepts, right? The basic stuff, right? So today it's the clinical skills session, right? Now, today's approach is a little bit different, guys, okay? Today, it's going to be more of a discussion than yesterday, right? Yesterday was a lot of basics we did on the board, right? Today also will be there, but majority, I want you all to communicate with me and, discuss the session with me, right? And by the way, if there's any connection related issue, anything, just drop a message to any of the admins, group admins, except for me. Don't drop any messages to me. I won't be checking my phone. Yeah, so let's get started. Now, so yesterday, guys, what did we talk about? We started off with the patient coming to us, right? Some sort of weakness. It can be motor, sensory, right? They're going to come with some sort of weakness, problems with movement, right? Sensation. And what we discussed is, firstly, we identified which side of the brain the problem might be in, right? Next, what we did was we identified which part of the brain, right? Specifically the cerebral cortex, which part of the brain was most likely affected, right? And after that, we went on to describe which artery was probably involved, right? Which vessel was probably involved. Because if you all remember the definition of stroke, it's an acute onset vascular event, right? Right. Then after that, what did we talk about? Based on the homunculus, we discussed which part of the brain might be involved and the blood vessel. And finally, we talked about the possible causes, the underlying etiopathogenesis also we've discussed, right? So we built up the classic picture of our stroke, right? Our patient coming in with contralateral side, right? Weakness, motor, sensory, we've discussed both. And if you take the face, the contralateral lower half of the face, right? We've discussed that much, right? Now, so today we are going to start off with what else. So that yesterday's discussion, guys, that is enough for you all to diagnose majority of your stroke cases, right? 70-80% of your stroke cases you can diagnose from yesterday's session, right? Today we are going to learn some additional. Firstly, we are going to start off learning some additional clinical features that we are going to look for, right, in the patient. Specifically when the manifestations are not very clear for us to think if this is a stroke, this is some sort of other neuromuscular problem, right? There are some specific signs that we are going to talk about, right? Some specific syndromes, right? So you guys can take out the note. If anyone doesn't have the note, again, drop a message to any of our coordinators. Yesterday also there was an issue. Some students haven't received the note on the group, right? So just give me a second. Let me share the screen. Give me a second, guys, until this connects. So who's here? Any new faces? Lula, is it? Am I pronouncing it correct?
Yeah.
Which university?
Nanjing Medical.
All right. Okay, great. Taimur is here. Shashank is here. Good. Right. Okay. Mesh. Right. Okay. Guys, what is up here? Give me a second. Either I'm getting too old for technology or something else is going on. Right. Can you see the screen, guys? Not yet? No? Yeah? Right. Excellent. Thank you, Imesh. Right. Give me a second, guys. Okay. You all can see the screen, right? All good? Second. Okay. Right. So let's start. So today we are going to start off with these clinical syndromes, right? Clinical syndromes. So we are going to see MCA syndrome, ACA syndrome, right? PCA syndrome, and some watershed areas, right? We'll see what those mean. So first of all, now this is going to be more of a discussion. Now I want you all to talk with me, okay? Don't be shy, unmute and talk. Okay, right. So based on yesterday's things that we studied, right, we will start off with what we call the MCA syndrome, middle cerebral artery syndrome, right? So first of all, guys, what do we mean by a syndrome? A group of clinical manifestation, a group of disorders, right? So when we say MCA syndrome, here there are a group of manifestations that are associated with middle cerebral artery type strokes, right? That's what we are going to talk about. So if we say motor and sensory impairment in an MCA syndrome, now someone unmute and tell me, in an MCA syndrome, what is the motor and sensory impairment that we are going to see? It's okay. No wrong answers, huh? Don't be afraid to talk. Just unmute and talk. Yesterday we have discussed this. MCA syndrome, what are the motor and sensory impairments that we see?
Mostly regarding the trunk and the...
Sorry, Shashank, sorry, I did not hear you.
But then mostly regarding the trunk and the face.
Face, more than the lower limb, right? More than the lower limb, right? Good. So upper limb and face affected more than the lower limb. Excellent. Excellent. So how do we say this, guys? So when we are talking about the motor, how do we explain it? Spastic type, like you can write down, huh? Spastic type of weakness, because we discussed yesterday, upper motor neuron means spastic type of weakness, right? So spastic type of weakness, right? In the contralateral side, right? Contralateral side, always mention that, contralateral side, right? And you have to say upper limb plus or minus face is affected more than the lower limb. Okay. Upper limb plus or minus face, we discussed yesterday, plus or minus the face, right? Affected more than the lower limb, right? Lower limb. So that is the motor impairment, right? Spastic type of contralateral weakness. You all can call it contralateral hemiparesis or hemiplegia, right? With the upper limb and the face affected more than the lower limb, right? Then what about the sensory? If someone asks you, what is the sensory impairment we see? How will you tell it? How will you respond to that question? Sensory, guys, what we see is, again, contralateral side, sensory impairment. Contralateral side, sensory impairment or sensory loss, right? So that part we have discussed yesterday, motor and the sensory impairment. Today, we will go to the other symptoms, right? The other symptoms, what we are going to see. The second one, we are going to start off with visual defects. Visual defects. Now, with the middle cerebral artery, guys, there is an additional area. I have drawn this in blue for you all, right? Right here, right? When we look at the frontal cortex, right? When we look at the frontal area of our cerebral hemispheres, right? There is something called, this blue area that I've drawn is called the frontal eye field area, right? Frontal eye field area, right? Now, so this is found in the frontal lobe, right? And it is also, if you remember the lateral aspect, if you remember the blood supply of the MCA, you remember that all of the lateral aspect of the brain, the cerebral hemisphere is supplied by the MCA. Whereas the medial, the midline, yesterday we talked about, is supplied by the ACA. So this area also, the FEF, or what we call the frontal eye field, is also supplied by the MCA, right? Now, what happens when there is a MCA stroke? This frontal eye field function is lost. So we have to understand what the frontal eye field function is, right? So for this, guys, we have to understand the basic eye musculation, right? So if you take an eyeball, right here, I have drawn the left and the right eyeballs. So for one eyeball, we have 6 extraocular muscles, what we call extraocular muscles, right? So if we take this left eye that I've drawn, right? So this will be the lateral rectus, right? The lateral rectus. Then we have the medial rectus, which is at the nose side. At the nose side, it's medial, right? And then we have the superior rectus and the inferior rectus, right? Then we have 2 oblique muscles, these yellow color ones, the superior oblique and the inferior oblique, Okay. So now if we forget the right eye for a moment and if we focus only on the left eye, what do these muscles do, right? The lateral rectus, guys, in a normal person, what it does is it takes the eye to the lateral side, right? Away from the midline. What does that mean? What is the fancy word we want to use there? It abducts the eye, right? AB, right? AB ducts the eye, right? Abducts the eye, right? Whereas if you're talking about the medial rectus, what is it doing? Adduction, right? Adduction of the eye. Okay. And then superior rectus, inferior rectus, it's very obvious, guys, just moving up and down, right? These oblique muscles, what do they do, right? This oblique muscle group, guys, from the way they have been attached to the eyeball, you all can see if they contract. Now let's look at the superior oblique. If it contracts, guys, it pulls in this direction, right? It pulls in this direction, right? Like that, like that. So what will happen to the eyeball? The eyeball comes like this. What do we call this movement? It is rotating towards the nose, right? What do we call this movement? Intorsion. We call it intorsion, right? Intorsion. Then the inferior oblique does the opposite, right? If you look at the inferior oblique, it does the opposite. So it pulls in this direction, right? So it moves like that, right? What is that? Extorsion of the eye. Extorsion, moving towards the outside, right? Rotating towards the outside. Okay, that is extorsion of the eye, right? So if you all understand this, now the pathology becomes a little bit more simpler, right? Now let's take a look at what is happening. Now I will draw this frontal eye field area. Let's say this is our right cortex, this is our left cortex, right? I will draw the frontal eye field area in the right cortex, right? Somewhere here, right? Somewhere here. Okay, now there is a stroke that has happened, right? There is a stroke that has happened in this area involving this region, right? Here, guys, first let's check. Okay, forget the stroke. Let's take a second to see what happens without the stroke, right? So that you all understand the normal physiology. In the normal case, guys, from the frontal eye field, right? There is so you all know the motor. Yesterday we talked about, when we talk about the motor system, there's an upper motor neuron and a lower motor neuron, right? Same system here, right? So we have an upper motor neuron coming here from this frontal eye field zone, right? So the upper motor neuron comes, guys, it comes all the way to the opposite pons. This is the pons, huh? This is the pons, right? And we can put a midline there, right? So it comes to the opposite side pons, right? Opposite side pons. Here, this guy will meet with another neuron. It will meet with the second neuron. Here, guys, it's a little bit different than our classical motor pathways. This guy meets with a special type of neuron called a relay neuron, right? Now, this one has a name, right? We don't need to know, right? A little bit confusing. So I will not mention the name. I just know that this is a relay neuron, okay? This is a relay neuron. Now, what happens from this relay neuron? This will give out two, right? You all can see two connections, right? Two are given. What are these two nerves that are coming out? Right? Look at this, guys. There is one nerve that comes here, right? So again, if we look, this is the left eye, this is the right eye, right? For the left eye, there is one neuron that is coming and supplying the, let me draw these four muscles again. No need to draw all four, just these two are enough, huh? Right. For the left eye, that means the contralateral eye, right? The opposite side eye, there is a nerve coming and joining to the lateral rectus, right? This is the lateral rectus of the left eye. Everyone agrees, right? If this is the nose here, if this is the nose, that is the lateral rectus, right? Then there is also the other nerve that is coming from this relay neuron, right? This guy comes and joins to the medial rectus of the right eye. He comes and joins to the medial rectus of the right eye. So what are these, right? What are these nerves, guys? Let me put this guy in a different color. I'll make him purple, huh? So that it's clear, right? Okay, the yellow guy. What's the name of the yellow guy, guys? Lateral rectus is supplied by which nerve? Sixth nerve, yes, abducens nerve, right? Sixth nerve, sixth cranial nerve, what we call the abducens nerve, right? Abducens nerve, okay? And the medial rectus here, guys, this is by the third cranial nerve, right? Don't worry, juniors, if there are any first, second years here, right? We'll talk about cranial nerves. It's a different chapter, right? I will teach that to you all later, right? For now, just know this is the third cranial nerve, right? Okay, ocular motor nerve. Okay, so this is the normal supply. Now look at this, guys. Now based on this diagram, now imagine there is a stroke in this area. There is a stroke. I've colored it black, right? There is a stroke. Now what is going to happen, guys? So what is the normal function of these two muscles that were supplied? The lateral rectus will do what? The lateral rectus will abduct the left eye, right? Whereas the medial rectus will adduct the right eye, right? That medial rectus there will adduct the right eye. Now what is happening when there is a stroke in this area? These two functions are gone, right? These two functions are gone. Okay, everyone agrees up to that point. Give me a thumbs up, right? Right? Okay, good. Now, there is an issue, right? True. When the right cortex has a stroke, now these two functions are gone. But you all must know, from the left cortex, we get this same supply, same thing happening on the left side, right? On the left side, there is a nerve coming like that, right? One supplies here, this guy supplies here. right? So if you can see, guys, now we know muscles always work in pairs, correct? Muscles always work in pairs, right? So if there was a right-sided stroke and this lateral rectus of the left eye and the medial rectus of the right eye is gone, the other two muscles, right? What do we mean by the other two muscles? This guy and this guy is now unopposed, right? No one is there to pull him, right? Okay. There is unopposed action on that side, right? So what will happen when you tell the patient, guys? You tell the patient, okay, look straight ahead. What is going to happen, guys? Where is he going to look at? His eyes are going to look at the right side because his left-sided gaze is gone, right? His left-sided gaze is gone and the muscles that are working for the right-sided gaze are now unopposed, right? There is no one to oppose those two guys, okay? So there is an imbalance of power there, right? There's an imbalance of strength, you can call it, right? And the eyes are going to shift to the right side. Now, what is a fancy way to say this, guys? What is a nice way you can say this? The eyes are looking. Sorry? Yes. We'll come there, right? Yes, you're correct, right? What I wanted to say was the eyes are looking at the lesion, right? The eyes are looking at the lesion. Why? The lesion is on the right side. The eye gaze is also towards the right side. Okay? Eye gaze is also towards. So what we say is the eyes are looking at the lesion, right? So this is, you're correct, Shashank. This is called ipsilateral. Why are we saying ipsilateral? It's the same side as the lesion, right? Ipsilateral gaze deviation. Okay. Everyone agrees, right? Okay. Let me see some faces. Today's content is a little bit heavy, guys, but if you'll stick with me, don't worry. I will make it as understandable as possible, right? Right. Got it? Okay. Then, so ipsilateral gaze deviation is done. Then, guys, there is another thing. Now, everyone is familiar with this diagram, right? Everyone is familiar with this diagram since your second or third year, right? So let's go ahead talking about that also a little. Look at this, guys. We have what we call, our visual field, right? Our visual field. What I want you all to understand is, guys, in our visual field, we are not going too deep into this, but what I want you to understand is, you all know the portion, the parts here, right? Okay. So here, this is the retina, right? We have the retina there, right? Retina. The retina, I've divided it into the medial retina and the lateral retina. That's the yellow and the purple, right? Everyone is familiar with that. Then we have this is the optic nerve, right? The optic nerve, right? Here we have the optic chiasm, right? The optic chiasm, right? Then we have the optic tract, the tract here. This is the lateral geniculate body, right? Lateral geniculate body. And here we have what you call the optic radiation, right? The radiation, right? From the optic radiation, where does it go to, guys? It goes to the visual cortex, right? Now, the visual cortex is found where, guys, in our brain? Where is the visual cortex? This is in the?
Yes.
It's in the occipital lobe, right? It's in the occipital lobe, right? Excellent, right? So we'll keep the visual cortex for a while. What I want you all to know here, guys, the radiation, the optic radiation is within the area of the middle cerebral artery, right? The optic radiation is in the MCA territory, what we call the MCA territory, right? Okay. So if there is a MCA infarct, right? MCA infarct. Now I will say this is the right and this is the left. Okay. Okay. And again, right-sided eye and left-sided eye, right? Now look at this. If there is a MCA related infarct, what will happen? This optic radiation will be gone. The optic radiation will be gone, right? If that is the case, guys, now you all follow this yellow and the purple lines and see what is happening. So one thing that will happen is, guys, this left eye's medial retina will be gone, right? Left eye's medial retina. And if you look at the right eye, the lateral retina will be gone. Right? Now, what is the normal functions of these structures, right? You all have already studied this in your second year, I think, right? If we look at the left eye, right? The lateral retina will take nasal vision. Now, here is my nose, guys. My nose is here. This is my nose. So, right? The left eye, the lateral retina will take the nasal vision, right? Okay. And if you take the left eye, the medial retina takes this lateral vision, right? Lateral vision. The same way for the other side. If you take the right eye, okay, the lateral retina will take the nasal vision, right? And the medial retina takes what we call the peripheral vision. So if you draw the eye field, guys, you draw the eye field somewhere like this, right? Okay, this medial vision is going to the two lateral retinas, right? It's going to the two lateral retinas, whereas the peripheral vision, these ones, right, is coming to the two medial retinas. Now, based on this, if I draw two eyeballs like this, right, now we are going to represent the loss of the vision. What is going to happen, right? If you take the left eye, guys, what did we say? Medial retina is gone. Medial retina takes lateral or peripheral vision from the left eye. So that means if I take this as the left and this as the right, guys, this vision is gone. Okay, like that. Okay, everyone agrees? Right? Okay, right. If you take the right eye, what is happening? This vision is gone. Okay, right? Now, where was our lesion, guys? Right-sided optic radiation, right? Right-sided optic radiation. Which vision is lost? Left-sided vision is lost. Left-sided vision is lost, right? You can see here both. This is, if you take one eye, this is the left vision and the right vision, left vision and the right vision. In both eyes, the left-sided vision is gone, right? So what is the fancy way to tell this? Contralateral. The lesion was in the right side. So contralateral, homonymous. Homonymous means they're same, appearing same. Homonymous hemianopia, half of the visual field, anopia, gone, right? Not seen, right? That is contralateral homonymous hemianopia. Okay. So these are some visual defects that can come when your middle cerebral artery is gone. Okay. Is everyone okay? Right? Right. Then let's move on. Right? Next, guys, we have some language processing problems. Right? Very interesting. Right? Listen carefully. Language, guys. Now, to process our language, guys, we have some specific areas in our brain. The problem is, now usually you all know, guys, if there is some area on the left side of our brain, it is usually there. A very similar area is also there in the right side, right? Right and left both have similar areas symmetrically for most of the time, except this language processing, guys. Language processing areas are only there in your dominant hemisphere. What do I mean by dominant hemisphere? If you're a right-handed person, your dominant hemisphere is left. What about if you're a left-handed person? What is your dominant hemisphere? Huh? What is the dominant hemisphere if you're a left-handed person?
Right.
Okay. Trick question,
Yeah.
right? Okay.
Left is usually 90%.
Yes,
of the
guys. Yes, excellent. Prashan, good. So, true. I mean, we might guess that if it's the opposite side, right? But actually, guys, in majority, even in left-handers, majority of the population, right? 85, 90% of the left-handers, still their dominant hemisphere is the left. Okay? Right? Right-handers, almost everyone is left dominant, right? Left-handers, majority of left-handers are still left dominant, right? So what does this tell you? If the patient is coming with some sort of language-related problem, there's a very, very high chance, be it him being right-handed or left-handed, there's a very high chance that there is a stroke in the left hemisphere, right? Left hemisphere. So we'll take a look at this. This language processing area, guys, if I draw the, I have drawn it for you all, right? If we take the left side, I have drawn the left hemisphere now. This is the left brain, right? Here in front of our central sulcus, there is one area in red, the one I drew in red, right? And then there's another one behind the central sulcus somewhere here, right? The one I drew in yellow. So this red one, guys, this red one is what we call Broca's area, right? Broca's area, right? Broca's area. Then here, the yellow one is what we call the Wernicke's area, right? Wernicke's area. So we have the Broca's area and the Wernicke's area. These are language processing areas. These are found in the left hemisphere, majority left hemisphere. Okay, right. Now, what are they responsible for? Look at this, guys. Broca's area in a normal person, right? This is for language production. Language production. What do I mean by language production? For you to talk, for you to speak with someone, right? Even writing, right? There is a path played by writing as well, right? So language production and language expression. This is the function of the Broca's area. Whereas the Wernicke's area, guys, right? This is language processing. Most of the time, what we say is it is for understanding written and verbal language, right? Understanding written and verbal language, right? So that's the function of the Wernicke's area. Now, right? Now tell me this. So if there is a stroke involving the left cortex, MCA territory, now this area, both of these are supplied by the MCA, right? This yellow area is MCA, right? MCA, right? So if there is a stroke in the MCA in the left cortex, we are going to get language related problems, right? If there is a MCA territory infarct in the right cortex, no language related problems. Okay. Remember that, right? Very rare language related problem, right? So let's look at what these symptoms are. If there is a Broca's area stroke, guys, if there is a Broca's area stroke, right? What are we going to see? Here, guys, now this is a problem with language production, language expression, right? So we call this expressive aphasia, right? Expressive aphasia. Okay. What is this expressive aphasia, guys? The patient can understand very well. When you talk with the patient, he can understand very well, right? But he cannot respond, right? He cannot find the words to respond to you, but he can understand. He can understand everything you're saying, right? So if they're now depending on the severity of the stroke, guys, right? Sometimes they might be able to say a couple of words, but again, it will be very short sentences. They will speak with very short sentences. If they say, I want to go to the shop, they will say, I shop, right? Something like that, right? They cannot speak complete sentences, right? And they can also have difficulty in writing as well, right? Difficulty writing as well, because this writing is also a part of language expression, right? Okay. And if it is very severe, guys, they might even have what we call just incomprehensible sounds. They can barely make any sounds, right? If it is very severe, right? They cannot talk. It's very difficult, right? But they can understand you very well. Okay. Right. So, and another thing is, guys, this one, write it down in red, right? In expressive aphasias, right? If you ask them to repeat something, right? You tell them a word, you tell them a phrase, and you tell them to repeat it, right? If you tell them to repeat it, they will not be able to repeat it, right? So for the Sri Lankan students in our local language, what we say is to repeat the word Prajatantravadya. That's a very, a little bit hard word even for normal people to say, but that's what we use to test it, right? Prajatantravadya. So we say that's democracy in Sinhalese, right? And in English, usually, these foreign Western countries, what they say is repeat the sentence, no ifs, ands, or buts. Okay. No ifs, ands, or buts, right? So they have to repeat that. If they can, they are usually okay. But this expressive aphasia in the Broca's region, they will not be able to repeat. Remember that later we will learn a condition where they can repeat. But again, there is an aphasia, right? We'll talk about that in a little bit, right? Right. So that's about Broca's aphasia. Now let's go to Wernicke's aphasia, guys. What is Wernicke's aphasia? Wernicke's, we said this is about language understanding. So what does this mean? When you tell them something, they cannot understand what you're saying, right? They cannot understand what you're saying. So there is misinterpretations, right? And inaccurate speech, right? So one thing, they cannot follow any commands, guys, because if you tell them, okay, take this pen, they will not understand that, right? So there is a lot of language related misinterpretation, inaccurate speech. Even if you ask them a question, right? If you ask them, what is your name? They will tell you their home address, right? Something like that, right? So inaccurate. And reading and writing both will be challenged here as well, because they cannot understand. Okay. So that is the difference between Wernicke's and Broca's aphasia. These are seen, remember, right? Specifically, especially for MBBS level, guys, right? For MBBS level, always remember it's left side, right? Left brain, right? Okay. Right. Now we are clear with that. Now, guys, so now we've talked about some symptoms that are very specific to both sides of the brain. That is the visual defects. Then we've talked about language processing, which is specific to the left side of the brain. There are also some features, guys, that's a little bit more specific to the right brain, right? Right brain. Again, rarely these can appear in left side also, but they're more specific to the right brain. What are these? It's apraxia and neglect, right? These are perception and processing issues, guys. Very interesting. Look at this. What is this apraxia? Now we know, let's say, if we have a patient, right? This is the right side, this is the left side, right? If we have a patient with a right-sided stroke, right? We know usually, they have a left-sided spastic type of hemiplegia. Everyone agrees? Left-sided spastic type of hemiplegia. But the right side is usually fine. Everyone agrees, right? Now what is going to happen, guys, in these patients with apraxia, we see some problems in the right side also. What are these problems? Look at this. These patients, guys, when we talk about this apraxia, this is a problem where their motor function is still fine. Motor function is still fine. Muscles are working fine, but they don't know how to do the action, right? What do I mean by that? Now they have a let's say right-sided stroke, left-sided hemiplegia, right? Now you tell them, use your right hand and take this phone, right? They see the phone. They understand that that is the phone. They want to take the phone, but they don't know how to move their arm, right? They can't figure out how to take their hand to that place and move it, right? If you check the muscle power in their right arm, all normal. Muscle power is normal, tone is normal, right side, everything is okay, right? If you do an electromyogram, it's normal. EMG is normal on the right arm, but they don't know how to do it. This is what we call apraxia, right? This is a difficulty in planning and performing motor tasks, right? Although the motor function is normal, okay, right? So there are multiple different types, guys, right? One is called this limb kinetic apraxia, right? Limb kinetic apraxia, the one that I just mentioned to you all, right? If you tell them to do something, they don't know how to do it. That is limb kinetic apraxia. Then we have another thing, what you call eyelid apraxia, right? If their eyes are closed, you ask them to open their eye, right? That same side or the opposite side, right? Whatever, they cannot open the eye. They cannot open the eye. Most of the time in the opposite side, they cannot open the eye. They don't know how to open it. Okay. Right. And then there's another one called executive. So limb kinetic. Then we have eyelid apraxia, and another one called executive apraxia, guys. Executive apraxia, right? It's very interesting, guys, right? There was actually during my internship back at NMU, right? We actually saw a patient, right? This executive apraxia, you give them a paper and you give them a marker, right? You tell them, write something, write anything, right? They identify this as the marker. They identify this as the paper, right? And you can even tell them specific, you write anything. Do you know your name? You ask, do you know your name? They know their name. Okay, can you write your name, right? They know how to write, but they can't write. Okay, they know how to write, but they can't, right? So these patients are, guys, they are sometimes very frustrated, right? Because you can understand, right? Everything is working fine, but they just don't know how to do certain actions. Okay, so very interesting, right? So this is about apraxia, guys. Apraxia. Now the exact areas responsible in the brain, we don't need, guys. There are actually multiple. These are not one area related stuff. There are 2-3 areas involved, right? Big names we don't need to know, right? This is more than enough. The other one is, guys, neglect. This is another very important one, right? Neglect, guys. What is happening is they will neglect any sensation or even sometimes motor functions, right? Sensations or motor functions from the contralateral side of the body. So if they have a right-sided stroke, they are going to neglect everything on their left side. What does that mean? Let's say the patient comes into the room, right? Let's say there are three doctors, right? And the patient is seated here. This is the patient, right? And now he's having a right-sided stroke. Right? Right-sided stroke. What you ask the patient, how many people can you see in the room, right? He will say 2. He sees only these 2. He is completely neglecting this left side. Okay? Completely neglecting the left side. Right? This is called hemispatial neglect. You tell them to draw a clock, guys. They will draw something like this, right? And they will put all the numbers here. 12, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, right? And you tell them to mark a time, they will mark it very weirdly, right? You tell them 2:30, they will put something like this, 2 and half of that circle, half of that hemicircle, right? Okay. So this is again another feature of hemi neglect, right? The rest of the clock, they won't draw it. Okay. So these are features mostly seen in right-sided MCA territory stroke, guys, right? Okay. Right. Again, the areas we don't need, guys, for this neglect as well, right? It's a little bit complex. There's a superior colliculus. There's an area called the pulvina, right? We don't need to know, right? Just know this. These are more specific to the right brain. Okay, right MCA territory. Right? Everyone clear up to this point? All good? Right? Okay. Then, guys, there is another thing that we need to talk about. These lacuna infarcts. Now, This lacunar infarcts, guys, I put it under the MCA because this is where we most commonly see the lacunar infarcts. But remember, I have put it in this sentence as well, the ACA. Here, there's a small spelling mistake, correct that, ACA. ACA, PCA, basilar artery, those also can give rise to even the circle of Willis, right? Those also can give rise to lacunar infarcts. But most common you will see in your day-to-day practice is the MCA. That's why I put it under MCA, right? Okay. So what are these lacunar infarcts, guys? These are tiny infarctions. Now, look at this. If the infarctions are tiny, guys, let's say something like this, right? If the infarctions are tiny, let's say it's a tiny, 1 or 2 infarctions, right? Tiny infarctions are there. What do you think about the resulting defect, the neurological deficit? What do you think?
Would also be limited.
Sorry, Shashank, I didn't hear you.
It would also be limited to...
Yes, correct, right? So lacunar infarcts, they are generally also very limited, as Shashank says, very limited neurological deficits. But there's a big but here. Okay. Right. What I mean is, right, look at this. If we take, I have to be very careful when using language, right? If we take the left and other way, right? Sorry, left and right. If we take the left and the right hemispheres, right? Now let's I will say there is a normal stroke. Now forget about lacunar stroke for a second here, guys. Let's say there is a normal stroke here, a big one, right? And on my right side, I've drawn a lacunar stroke just to compare. I'm not saying that the same person is having both infarcts. I'm just drawing to compare and show you all. On this right side, I have drawn 2 small lacunar infarcts. Majority of the time, just like Shashank said, these are minor deficits and they are often undiagnosed, guys, right? They are often undiagnosed. The patient won't even show any clinical features, right? And you will usually see them in accidentally. You will see them in a CT or MRI that the patient has done for something else. But the important point I want you all to understand is lacunar infarcts, multiple can happen over a period of time without giving manifestations, right? So let's say if I take that same area, over a period of time, multiple can happen and suddenly one of those lacunar infarcts will jump the threshold and give the full clinical manifestation, right? So what do I mean? What I'm saying is this size will be equal to multiple lacunas of this size. Everyone agrees? Right? Infarct size of the brain, right? Infarct size of the brain, right? So just remember, guys, although lacunar infarcts are tiny infarcts, over the course of time, they can progress, right? They can develop more and more lacunar infarcts, giving full neurological deficits, just like a normal stroke, right? Okay. So what do you think? Based on this information, when a patient comes with a stroke, can we immediately say this is a normal stroke or this is a lacunar infarcts, multiple lacunar infarcts that have occurred? It's a little bit difficult to say, right? Because the clinical picture can be same. It can be multiple lacunar infarcts or one major stroke, right? How do we identify? There are some features specific for lacunar infarcts, guys. Now, what are these features? Those are the ones I want to talk about now, right? There are a few features that are specific. One is, right, if these are small lacunar infarcts, like Shashank mentioned, very limited neurological deficits. So we can have what you call a pure motor stroke, Now, if we are saying pure motor stroke, can someone tell me where in the brain is this happening? Where in the brain? Okay.
Precentral.
Yes, excellent. In the motor cortex, in the precentral gyrus only, right? Precentral gyrus only, right? Now, usually when we are having strokes, we are having both the precentral gyrus and the postcentral gyrus involved. Now, for students who are new to today's session, we have discussed precentral gyrus, postcentral gyrus in the homunculus video. It's on YouTube, right? You all can go check it out. Right? It's a 10-minute video. Check it out, right? So they can have what we call this pure motor stroke. They will only have motor symptoms, guys. They will not have any sensory loss, Then there is also, if the postcentral gyrus is only involved, we can have pure sensory strokes, right? Okay. Right. So these are coming with lacunar infarcts. The other thing is, guys, very interesting one. Write this down. It's called dysarthria, clumsy hand. Dysarthria, clumsy hand. What is this? Dysarthria? What is dysarthria, guys? Inability to articulate. Articulate means what? Talk. Inability to talk. Now, dysarthria is a problem. What is the difference between dysarthria and aphasia? Previously, we talked about aphasia. Aphasia is, guys, there is a brain problem where language processing is involved and therefore they cannot speak. Whereas dysarthria, the language processing and everything is fine, but they cannot speak due to their voice box muscles aren't working. Their tongue is not working, right? The muscles that they need for communication is not working. That is dysarthria, right? That's the difference between dysarthria and aphasia. Okay, right. So the tongue, the larynx, right? All of these voice box related muscles aren't working, right? So they will have what you call pronunciation problems. They cannot talk fluently. There is no fluent speech, right? In dysarthria. Then the other thing is now this disorder is known as dysarthria clumsy hand. What is this clumsy hand portion of this? Clumsy hand is, guys, this is now, since this is a small stroke, right? Lacunar infarct is a small stroke. So there is not a full-on paraparesis or a paraplegia. There is no hemiplegia or hemiparesis. It's just what we call clumsiness, right? Especially this is seen in the superior extremity, guys, right? Their motor strength is actually normal, right? Their motor strength is actually normal, but again, they can't do fine activities, right? You tell them to tie a shoelace, they cannot, right? You tell them to write something using a thin, like a ballpoint pen, it's difficult for them, right? So fine motor activities are a little bit lost, right? So this is what we are calling clumsy hand, right? So again, this is seen in lacunar strokes, okay? Right? Dysarthria, clumsy hand, okay? Then the next thing is, guys, next one, the fourth one, right? Ataxic hemiparesis. Now, this one, we are not going to go into depth, guys. It's a little bit complex, but just remember, they can also have balance related problems with their hemiparesis, right? They can have a hemiparesis as in a normal stroke, but they can also have ataxia involved with it, right? Here, guys, if you all want to know seniors, remember, this is a corona radiator problem, okay? There is a portion called the corona radiator, right? This is a little bit deep, guys. That's why I didn't want to put it here. But you all should know that this ataxic hemiparesis can happen. Okay, just know that for now. That's enough, right? Otherwise, it might confuse you all. That's why I didn't put it here, right? Okay, clear. And apart from this, guys, they can also have, depending on the areas of the brain involved, right? Especially if the hippocampus and all are involved, they can have some memory loss, right? They can have some calculation, math-related problems, right? These kind of symptoms can be there, but those are not very common. These four, I want you to know. If someone asks you, right, or if there is a patient, right, that you're suspecting of lacunar strokes, these are the ones you want to look for, okay? These are the ones you want to look for, right? Okay, right. So that is done. That is the MCA syndrome, guys. Next, we'll move on to our anterior cerebral artery syndrome, ACA syndrome. Now, like the hemispheres that I have drawn here, ACA, if you all remember, it supplies to the medial region. I have highlighted that in yellow, right? The medial aspect, right? If you take the brain from the front, this entire midline. Okay, right. So again, just as as we started off with the MCA syndrome, what are the motor and sensory impairments that we see? We have already discussed this. What are the motor and sensory impairments in ACA syndrome? How do we describe it? Let's start with motor. Unmute.
Lower limbs more than face and
right, Shashank, I want you to tell me more beautifully, right? I want you to impress me. Lower limb more than, okay, I agree, but say it nicely. Complete it. What type of weakness?
spastic
Type. Spastic type where? Contralateral side. Right, excellent. Right, spastic type of contralateral hemiparesis or hemiplegia, right, with the lower limb affected more than the upper limb or plus or minus the face, right? Okay, right. Then what about the sensory impairment? Again, contralateral, sensory loss, again, lower limb affected more than the upper limb plus or minus the face. Okay, so this is what we discussed yesterday. Now we'll look at the other symptoms that are coming with this ACA problems, right? One is, guys, bladder and bowel incontinence, right? How is this happening, guys, right? We are not going to go into depth, right? There is an area in this ACA supplied area, right, called, you all can write it down, paracentral lobule, guys. It's a special area, right? The special area, right? It is also supplied by this ACA, right? And this one controls your bladder and bowel sphincter functions. Now, you all might be knowing our spinal cord also plays a major role when it comes to bladder and bowel incontinence, right? We'll talk about those in spinal cord lesions, right? That's another topic. But here, in stroke patients, also, they can have bladder and bowel incontinence, but that is not due to a spinal cord problem. It's due to this paracentral lobule being affected by the stroke, right? So they will go pee pee and poo poo, right? Okay. Right. Then the next one. Behavioral problems. Behavioral problems, right? I want you all to write this down, guys. I haven't put it here in your note, right? I have directly put the aphasia there. We'll put a number 5. That is 1, 2, 3, 4, and we'll put it as number 5, right? Somewhere here, you all can write it down. Behavioral problems, right? With this ACA, guys, with this anterior cerebral artery, right? You all know if we take our cortex, right? Draw that nicely, right? Something like that. Here, and this is all ACA, right? This is all ACA, right? You all know somewhere here, guys. Now, in front of the central sulcus, let's say this is the central sulcus. In front of the central sulcus, we get the frontal lobe. We get the frontal lobes of the cerebrum, right? Here, guys, at the very front, somewhere here, we have what you call the prefrontal cortex, right? We have the prefrontal cortex, right? This prefrontal cortex, guys, this one is responsible for some of our behavior and decision making, right? Behavior and decision making, right? So what is going to happen is, guys, when this prefrontal cortex is affected by this ACA stroke, we can have some clinical features. One of them is called abulia, right? Abulia, right? What is this abulia? Abulia is, guys, reduced motivation and willingness to do things. What does that mean? The patient does not want to do anything. Now, how many of you all are going to self-diagnose? No, this is not procrastination. Okay. There is a difference, right? Procrastination versus abulia is different, right? Abulia is they do not want to do anything, not on purpose. Okay. Not on purpose. Procrastination is you don't want to do something on purpose, right? That's a different scenario. Now, in abulia, what is going to happen because of this? How is it clinically going to be evident, guys? When you give the patient some sort of command, when you tell them, okay, do this, right? Take this cup of water, right? Write your name on a piece of paper with a pen. What is going to happen is they are not motivated to do it, right? So what they do it very slowly, guys. There is a significant delay in their motor and verbal activities. Even their verbal activities, if you ask them to tell you something, tell your home address, they will tell it very slowly, right? Very slowly. It will take them about 5-10 minutes to tell their home address, right? Okay, so this is abulia. Now, this one, guys, it depends, right? How severe. Now, depending on the severity of the stroke, sometimes if bilateral prefrontal cortices are involved, if both sides prefrontal cortex are involved, what is going to happen? You're going to see what you call akinetic mutism, right? So akinesia, they won't move at all. And mutism, they won't talk at all. Okay, right? Not because they don't have the ability. They have the ability, right? Motor function and everything is working. They just don't. They don't have the motivation to do it, right? Okay, this is what happens when you have prefrontal cortex problems. Apart from this, guys, there is also personality expression problems. What are these personality expression abnormalities, guys? Socially inappropriate behavior. What we call socially inappropriate behavior, you're going to see when this prefrontal cortex is involved, right? So aggression, right? Have you all heard of Charles Whitman, guys? Have you all heard of Charles Whitman? Yeah. The American, he was a veteran, right? He went on a rampage. He killed his wife and his mother, and then he went to a school in Texas, and he went to the top floor, right? And he started shooting. He was a sniper, so he started shooting people using a sniper, right? But the thing is, first he killed his mother and his wife. I don't know if you all have heard the story. Very interesting, right? First he killed his mother and his wife, and he wrote a note saying he doesn't know why he did it, right? Even before doing all this murderous stuff, he has gone to multiple physicians saying, right, he's having abnormal thinking patterns. He feels aggressive, although he doesn't like it, right? Things like that. So end of the day, after this incident happened, they killed him. They apprehended, they killed him. But in the autopsy, they found a large brain tumor, right? Pressing on this prefrontal cortex region, right? Very large tumor, right? Very interesting story. There is a movie, actually, I haven't watched, but there is a book, right? There is a book also. Just type Charles Whitman book. This is 1950s, right? Very interesting, right? Or you can watch the movie. Movie is also there. I'm not sure how good the movie is though, right? So that was actually a tumor, right? We are not talking about tumors today, but again, right? Personality expression related to this prefrontal cortex, very important, right? So if there is a stroke, this can happen. This can happen. Okay, right? Everyone good? Give me a thumbs up to this point, right? Okay, right. Excellent, excellent. Let me see some other faces. Satsarani, all good? Right, thumbs up. Yeah, okay, excellent. Who is here? Abash is here. Hi, good. After a long time. Right, okay. Shiza, all good? Right? Okay, right, excellent. Right, let's move on, guys. Then the last one for this ACA syndromes, right? This aphasia. I told you there's another aphasia that we are going to talk about. That is this transcortical aphasia, right? Now, what did we talk about, guys, before, right? We talked about the Broca's area somewhere here. We talked about the Wernicke's area somewhere here, right? And we talked about those aphasia, Broca's area, Wernicke's aphasia. There is another, those were MCA related, right? Those were supplied by the MCA. There is another area, guys, somewhere here. Again, we are not going to mention the name within the ACA territory, right? It's actually in the supplementary motor cortex, right? No need to know, right? This one constantly communicates with these Broca's, right? And helps with language processing, right? So again, when this area is involved, guys, they can also have aphasia, but the important thing is this area has nothing to do with language repetition, right? Therefore, what happens? They do not have a problem with repetition. You tell them to tell a word. You tell them to tell a sentence. No ifs, ands, or buts, right? They can say it. No problem with repetition. Okay, right? So this is important. Okay, this is called transcortical aphasia, right? Okay, right. So that's about it for the ACA syndromes, guys. Next, we will go to what we call the watershed zones. What are these watershed zones, guys? Now look at this. If we take a top-down view, now I've drawn this top-down view. I'm looking at the brain from up, right? From up above, I'm looking down at the brain. If we take a top-down view, this black line that I've drawn in the middle, this is our central sulcus, right? So if I say that, if that is the central sulcus, all of this yellow highlight area, you all know that is going to be supplied by the ACA, right? All of the yellow highlight area. Then if I highlight another one in blue, all of this structure, the lateral aspect, this is going to be supplied by the MCA. You all are familiar with this also. Then at the very back, we won't usually see it in the posterior view, but I will draw it here at the very bottom, right? Somewhere here, we'll have the PCA supply. Okay, everyone agrees with this, right? All good. Now, guys, what is the important thing here, right? Look at this. Also, look at this. There are what we call watershed zones. What are these watershed zones, guys? These are where two zones meet together. So, for example, where the ACA and the MCA meet, right? That is this zone that I've colored in red, right? Okay, there is another zone, right, where the MCA and the PCA meet. That is this zone that I'm coloring from blue, right? Okay, these are what you call watershed zones. Why do we call watershed zones, guys? Now, let's say there are some, if I draw the arteries roughly, right? The MCA arteries will be like this, and they will end near this watershed zone. ACA arteries will be like this. They are also ending at this watershed zones, right? So what is going to happen, guys, in these areas, what do you think? They are very susceptible, right? All the end arteries are here, right? They are very susceptible to ischemia, right? Because they are receiving the least amount of blood, okay, at these watershed zones, right? So if they are receiving the least amount of blood, in case of ischemia, they are going to show some symptoms. But what is the important thing? What do you all think based on this diagram? What do you all think is important about these findings, the clinical features? How will the patient present to you? All right. What do you all think? Will they present? Okay, let's first talk about the MCA, ACA watershed zone. ACA watershed zone. That means this zone A that I've drawn in red, right? If we are talking about zone A related or this red area strokes, how do you all think the patient will present? More with MCA symptoms, more with ACA symptoms? What do you all think? Huh?
The patient can have variable presentation.
Excellent, right? Patient will have variable presentation. They will have what we call a mixture, right? They will have a mixture of ACA and MCA symptoms, right? Very good, Arshin, right? Good, right? So here, guys, there is a very specific thing. Now, if you all look specifically at the homunculus, right? If we look at the homunculus, right? You all remember this area was ACA, the red one, right? That I'm coloring. Then somewhere from here to here, this was all MCA. So what is this watershed zone in fact? Somewhere here. So if you all remember the homunculus, right? We drew the leg, dropping into this valley here like this, right? And then we had a little bit of the trunk, and we are starting the hand off somewhere here, right? Hand, and then here is the face, right? This was the homunculus, no? So in this, guys, if you can see this hand, the shoulder area is coming towards this, what you call our watershed zone, right? Then the upper extremities of your leg, right? The thigh area and the trunk is coming more towards this watershed zone. So this will give a characteristic clinical picture, guys, right? Look at this. They can have mixed symptoms, as you mentioned, that is correct. But there is also what you call the proximal ends are showing some manifestation. So if you take the hand, the proximal hand, right? So the arm, the forearm will be normal. Forearm and the hand is usually normal, but the proximal ends will be affected. And if you take the leg, more around this region, and the trunk also can be affected. So this is, guys, you all know in the military, right? They do this ice, they dip into the ice buckets for the military training and all of that. So this, they call it, like when they dip into the ice, right? They're all squished inside the barrel, right? So this is something like that. Just get the picture like that. Why they call it that? They call it the man in barrel syndrome. So the proximal limbs, right? The proximal limbs and the trunk can show the manifestations. Okay. This is what we get when we get a watershed zone. So that is for the ACA, MCA watershed zone. Okay. Right. Just remember that. Right. So if there is a watershed zone infarct, guys, watershed zone infarcts, what do you all think? Usually are the symptoms unilateral or bilateral? What do you all think? Usually for the most part. Now I drew the man in the barrel also. So you all should answer.
Bilateral.
Yeah, they tend to be bilateral, guys. Why do they tend to be bilateral? These watershed zone infarcts, guys, they are most commonly seen not with the ACA only region, right? Not with the anterior cerebral artery only affected, or not with the middle cerebral artery only affected. They are usually seen in maybe like an internal carotid artery lesion, right? Because you all remember, internal carotid artery is the one that comes and splits into the ACA and the MCA, right? Yesterday we've discussed the blood supply. So usually the watershed zone lesions are seen in these large vessel ones, right? Like the internal carotid artery, right? So most of the time, the symptoms will tend to be bilateral, right? Most of the time, not all the time, right? Remember, they can have unilateral symptoms as well, but most of the time it's this man in the barrel syndrome. Okay. Right. So if I'm telling you all that most commonly these occur due to internal carotid artery problems, ICA related problems, right? ICA related ischemia. If that is the case, what else can you see in this ICA related problem? Now this is time to go back to our blood supply. Yesterday, guys, you can see my screen, right? Here, right? We discussed the blood supply, right? You all remember, actually, I did not mention this yesterday, but if we look at the picture here, we can clearly see there is this other branch that is coming out of this system. Here, I will color it using blue, right? These two. What are these two? These are ophthalmic arteries, guys. Here in the side view, you can see it very clearly going towards the eye, right? These are ophthalmic arteries. They are also coming out of the internal carotid, right? So apart from the ACA and the MCA, internal carotid is also giving this ophthalmic artery branch, right? Okay, no more specifically later it further divides, and there is something called the retinal artery. Superior retinal artery is also be there, right? But for now, just know ophthalmic artery. Now, so if there is an ICA problem, right? If there is an ICA related problem, what can happen, guys? Specifically, this is seen in transient type of ischemia, what we call transient ischemic attacks of the ICA, right? We can have the patient coming and telling you, doctor, look, last night, I don't know what happened, right? Suddenly my left eye stopped working. I couldn't see using my left eye. Today morning, it's fine. Right? They can have transient unilateral or bilateral, depending on which internal carotid is occluded, right? They can have transient visual loss, right? It is very common unilateral transient visual loss. What is this, guys? We call it, this is a nice name, right? Amaurosis fugax, right? This is amaurosis fugax, right? This is seen in transient ischemic attacks, TIA, right? Monoocular visual loss, temporary. If it is not managed, can cause permanent blindness of that eye. Okay, right? Right. So if the patient comes and complains, you must immediately. We'll see the management today. We have to do NCCT. Right? We'll talk about management today. Right? Immediately, you need to look into. Okay. Right. So that's about the watershed zones, guys. Right. Then we'll talk a little bit about PCA syndromes. We won't talk about much here. PCA strokes, one thing is uncommon, right? Compared to our MCA and the ACA, right? So for the PCA syndrome, guys, the only one I want you all to know, what did we say about the visual cortex? The visual cortex is in the occipital lobe, right? Occipital lobe. So from the PCA, right? If there is a occipital lobe problem, right? Because you all know the PCA supplies to the occipital lobe. So we have the right and the left, right eye and the left eye, right? If there is a occipital lobe problem, now follow the lines and like our previous thing, can you all tell me what the eye field lesion might be? Huh? Right, this left eye and right eye. Excellent. Contralateral homonymous hemianopia, just like our previous one, right? Right? Contralateral side, homonymous hemianopia, right? Excellent. Right? Okay. Everyone clear up to this point? Right? All good. Right? Now, remember guys, the posterior circulation. Just a rundown from yesterday. What are the anterior circulation? When I say anterior circulation, what are the vessels involved? Anterior circulation? Come on, quickly. Unmute and talk. Anterior circulation. What are the vessels involved? Okay. Sorry. ACA, MCA, and the internal carotids, right? This is our anterior circulation. What is our posterior circulation? Our PCA, the basilar artery, and the vertebral artery. Yeah, that is our PCA strokes, right? Posterior circulation, right? Now, posterior circulation, so you'll see vertebral artery and basilar artery is also there. Basilar artery was supplying to what? If you all remember those tiny perforator branches, mostly our brainstem, right? If you all remember the diagram yesterday, right? You can see it here, right? This is supplying our brainstem right here, right? Parts of our brainstem, right? The perforators. Now, if it is supplying our brainstem, guys, the posterior circulation strokes, right, can have these PCA syndromes. The remaining manifestations will be related to our brainstem. What are those? Our cranial nerve palsies will be there. Now, this we are not going to talk today, guys. The cranial nerve palsies is a different topic, right? We'll talk about that later, right? So for PCA syndromes, what can you have? Contralateral homonymous hemianopia can be there, as well as cranial nerve palsies, right? We're not going to talk about that today, right? Is everyone clear up to this point, right? Okay. So we are done with the, with studying the mechanisms and the clinical features and the pathology and pathophysiology. Now we have to go, right, dive deep into our clinical stuff, right? So we are going to talk about history taking, how to diagnose, what questions to ask, right? What imaging studies to do. We are going to take a look at some CTs and how to manage. Now, send in the chat before we go here. Do you all want a 5-minute break or not? Give your opinion. Do you all feel tired? I know today's content is a little, no one. Okay, good. I'm so happy. I'm tired, but that is okay. It's okay. Right. Okay. Right. Okay. Let's go ahead. I'm happy. Right. So let's start off with our clinical skills, guys. Right. We are going to start off with history taking. Now, how is the patient going? Our classic patient, how is he going to come to us, guys? Classic patient is going to come, right? Remember yesterday we drew, right? If there is a right-sided stroke, right? There is going to be, contralateral, right? Spastic type for the motor, spastic type of contralateral weakness, right? And for the sensory, there is going to be sensory impairment or sensory loss depending on the severity. If you take the face, right? Lower half of the face will not have any motor function, right? We know this. So the patient is going to come to us. Now, very interesting, Patient will come and tell you all anything and everything, right? This is, I'm telling with personal experience, right? I had one patient coming and saying, my entire body is hurting. That was his chief complaint. How do you progress from there, guys? Right? Very difficult, right? Luckily, he had a drooping mouth. So it was okay. But if he didn't have, right? Big problem. Right? They will come and tell you anything and everything. So it's up to you to take the history. So when the patient comes and tells you guys, they will say, even if they say, I have pain or whatever, right? Your first thing is to localize. Where is your symptom? Ask from the patient. Take as many times you can ask, where exactly? Ask, right? Always, right? So patient will come and say, I can't do anything. Say, okay, what can't you do? Okay, he will say, I can't lift something. Okay, which hand? Right hand, left hand, right? Like that. Isolate, right? Isolate and go. Ask. So, locate what side his problems are on, because you all know contralateral side is the affected side, right? Contralateral side is the lesion side, right? So in your symptom analysis, the first thing is to ask about the symptom, right? Then guys, you ask about the event. That is the next thing. When we are talking about the event, guys, now this ischemic stroke, right? What the patient usually will come and tell you is either he fell down or he doesn't even know. He will come and tell you, doctor, my wife saw me fall down. I didn't even know what happened, right? Okay. Something like that. So you have to ask about the event. What do you ask about? Firstly, the onset. About the onset. What do you ask? What were you doing at the time of, first they will tell you they fell down or something like that. What were you doing at the time you fell down, right? That is the first question, right? What were you doing at the time? So I will just mention my patient because I will never forget that patient again in my life, right? He's a carpenter, right? He's a carpenter from Gaul, in Sri Lanka, right? And, what he said was he was lifting some heavy, he's a heavy alcoholic. I will give you all the story. Very interesting. Heavy alcoholic, heavy smoker, right? Heavy alcoholic, heavy smoker. Previous day, he has drank with his friends till like 3, 4 in the morning. Then 7 o'clock, he had to come to work, right? Heavily drunk, right? Coming to work. And now they had to put some wood that they had cut from a tree from the lorry. They had to take it down, right? From the lorry, from the truck, they had to take it down. So this guy was trying to help with that. Suddenly collapsed, right? That's how he said it, right? So what were you doing at the time, right? Then you ask second most important question, how long, now you came to the hospital now. How long did it take for you to get to the hospital since you collapsed? Okay. How long did it take? Why? We will see, guys, when we come to the management, there are specific times where we can use certain managements, right? We will talk about that, right? So the next thing is, how long did it take, right? The next thing, ask about, during the stroke, what did happen? Now, if the patient tells you he lost consciousness and fell down, fine. He has already told you. But if he didn't, you have to ask, did you fall down? Did you knock your head somewhere? Because those might be other problems, because now you all know if there is a hemorrhage involved, we cannot give thrombolysis, right? So there are problems like that. So you have to ask, did you knock your head? Was there any bleed, right? Did you lose consciousness? Was there anyone else around? Is that person here today? If that person is there, ask that person also some question, right? Okay. So like that. Next you ask about what happened during the stroke. Next you ask, guys, now after the stroke, let's say the patient lost consciousness, as in the case of our patient, right? After the stroke, did he regain consciousness? What happened after he regained consciousness? Was he able to move? You can ask, were you able to move as usual? So now you're saying your left arm was weak. Did you notice that soon after gaining consciousness, right? Or was it just before you came to the hospital, right? Like that, you have to ask step by step. Weren't you able to move your leg, right? All right. Were you able to speak? Now we saw some symptoms, right? With regard to language, right? Even when you're questioning the patient, you can see, guys, you can see if the patient is understanding you or not, right? So you can ask, right? Were there any language issues? Were there any calculation related issues? Right? Did you notice any pattern of thinking abnormalities? Right? These kind of things you can ask, right? Okay. Then you can also ask the symptoms. Now, after the patient regained consciousness, you can ask, did you notice now until you come to the hospital, did the symptoms get worse? Did the weakness get worse? Why? That might indicate there is still a hemorrhage going on. That is more pointing towards a hemorrhagic type of stroke, right? Symptoms getting worse and worse and worse over a little bit of time. That's more indicative of hemorrhagic than ischemic, right? Okay. So you have to ask these types of questions, right? Then you can also ask about any associated features, guys, right? Was there any headache, right? Because you all know, guys, you all have heard of something called a thunderclap headache, right? That is coming with something called subarachnoid hemorrhage, right? That is another entity coming under hemorrhagic stroke. So we want to exclude these kind of things, right? Was there any vomiting? Was there a seizure? Did you have a seizure? Right? Did you check your blood pressure? After coming to the hospital, did they check your blood pressure? What was the blood pressure? Right? Because you all know if the blood pressure is very high, again indicative of might be hemorrhagic type of stroke. Right? Okay? So you have to ask these kind of questions about the event. Right? The next thing, guys. Next, you have to ask a few questions to find the location of the stroke. Now, what is our location? What do we want to know? Is this an anterior circulation stroke or a posterior circulation stroke? Right? That is what we want to know. Right? So you ask about the weakness, right? The face, arm, and the leg. Right? You can then ask, was the upper limb affected more or the lower limb affected more? Right? Because you all know, right? In the MCA type of stroke, the upper limb and the face is affected more, whereas in the ACA, it's the lower limb affected more. So you have to ask these type of questions, right? You have to ask about the sensory impairment. Was there a sensory impairment with the motor impairment? Because if it is isolated sensory or isolated motor, what is that? Lacuna infarct, right? So these kind of questions you have to ask to try and find out the location and the type of the stroke, right? Then you can ask a few questions about posterior circulation, guys. Again, diplopia can be there, right? Not very important posterior circulation strokes for our level, but diplopia is coming. Why, guys, in posterior circulation? Cranial nerve palsies, right? So we'll talk about that in a different class, right? They can also have contralateral homonymous hemianopia, like we discussed, right? There can be impellence, unsteady gait, because you know the posterior lobes, the occipital lobes, right? They help with coordination. There can be slurred speech, right? All of these can be there. PCA, even if you all don't remember, for the most part, it's fine, but you all need to ask a few questions to exclude them, right? ACA and MCA, you have to ask full on, right? Okay, full on, you have to ask everything, right? Okay. Then, guys, next thing, ask questions to diagnose the type, right? Here, now, as we discussed before, hemorrhagic is the one we want to exclude. Our main focus is ischemic, right? Especially for the undergraduate level, ischemic stroke is, right? 99% you all are going to get ischemic stroke. But you all have to exclude hemorrhagic. Why? If it's a hemorrhagic stroke and you manage it as a ischemic stroke, you're going to kill the patient. Okay? You're going to kill the patient, right? So just ask a few questions for the ischemic stroke, guys. You all know about the risk factors, right? Yesterday we talked about the thrombotic phenomenon and the embolic phenomenon, right? So if you all remember that, just put that information here and ask questions. For thrombosis, what did we talk about? Atherosclerosis. So you ask about all the risk factors, right? Have you had any ischemic heart disease before? Do you have diabetes? Do you have a dyslipidemia, right? Hypertension. You ask all of that about atherosclerosis, our thrombotic phenomenon, right? Then smoking, right? Smoking, alcohol consumption, very important, especially smoking for stroke, right? Then you can ask about peripheral vascular disease. What's the relationship between peripheral vascular disease and atherosclerosis and stroke? Peripheral vascular disease. Sorry?
Embolism.
Excellent. Embolic phenomenon. So DVT and emboli, right? DVT and emboli, right? Okay, so you have to ask about peripheral vascular disease, guys. What is our clinical feature? What is the clinical feature of peripheral vascular disease? For the seniors, juniors, it's okay. I don't expect you all to know. Seniors?
Intermittent claudication.
Excellent. Intermittent claudication, right? Right? So you have to ask about all of the, you can ask about wrist pain, right? All of that you can ask, right? Next thing, about cardioembolism, again, there are a few things we need to ask. Has the patient had a myocardial infarction before, right? You can ask, does he feel any palpitations? Because you all know when there is mitral stenosis, yesterday we talked about, right? When there is mitral stenosis, there can be atrial fibrillation, right? Yesterday we talked about this, right? So they can have palpitations, they can have irregular pulse when you all are doing the physical examination. So you can check about all of these, right? For infective endocarditis, what can you ask? Have you had any prolonged fever, right? Any prolonged fever, right? For a long duration of time, right? And if the patient is not very clear about these responses, guys, you can ask, have you been given IV antibiotics, right? For a heart-related issue, right? These kind of questions you can ask. Okay, right? So that's about that, guys. And for vasculitis, right? Vasculitis is not very common, guys, not very common, but you can ask a little bit, right? So infection-related vasculitic problems and autoimmune-related vasculitic problems. So for autoimmune ones, you all know, you all can ask the usual autoimmune clinical manifestations. You all can ask, do you have any joint pains, any skin rash, right? Any loss of hair, alopecia, right? Ulcers, right? Oral ulcers specifically, right? You can ask these kind of question about and hematuria. You all know vasculitis. They can come with glomerulonephritis, so they can be hematuria, right? So you can ask about these kind of questions. And vasculitis, guys, specifically these autoimmune type of disorders. You all know, guys, can you all hear any sound? No, right? You all can just hear my voice, right? No issue, right? Yeah, there are some of my friends, squirrels, shouting outside, right? Sometimes very annoying, right? Anyway, right? For this autoimmune vasculitic problems, guys, they are fever. They can have fever. What type of fever do they have? Autoimmune conditions. What do you all think? Any idea? Is it a sudden relaxing and remitting type of spiky fever? Or is it a high grade fever? What do you all think? No. Autoimmune conditions, guys, these are chronic conditions, long-term conditions. They usually have low-grade fever, right? Persistent low-grade fever. Okay. So you can ask about these. Then about the infective vasculitic problems. Again, yesterday we talked about the syphilis, varicella zoster virus, right? These can be some causes. So you can ask, specifically, you can ask about STDs, right? You can ask, have you had multiple sexual partners? And you have to ask about unprotected sexual activity, right? Unprotected sexual activity you have to ask, right? Now you have to be tactful in asking these, right? Don't just, right? The patient will not tell you anything if you, right? Firstly, you have to be very serious when you're asking these questions. And usually, guys, in the history taking, when you're asking these, you give these kind of questions when you come to, you give them a small introduction to these questions. What I usually do is I say, okay, I have a few more questions to ask from you, so that it will help me narrow down the condition. So I want to ask you about your sexual practices, right? You give them a small introduction. You don't just jump in and say, how many partners are you having, right? He or she will not say anything. Okay, right? You have to be very tactful, right? Okay, right. So you can ask about the amount of partners and the unprotected sex you have to ask about, and also blood transfusions. Blood transfusion, you all know specifically for this infective endocarditis and all these conditions, right? If they've received blood transfusions, there is a high probability. And IV drug use also you must ask about, right? You must always exclude. Okay, right. Then guys, about the thrombophilias here, right? Thrombophilia, what are we going to ask is, what is this thrombophilia? Any condition. Now, yesterday we talked about the Virchow's triad, right? Any condition that is causing the blood to become more thrombogenic, right? To become increasing in chance of forming clots, right? This is what we call thrombophilia. So here we have, yesterday also we talked about polycythemia rubra vera, right? So you can ask this polycythemia word, guys. Patients know, patients who are having it, they know, right? What they're having, they know. So you can directly ask, you can use the word itself and ask, right? Have you been diagnosed, right? And then you can also ask about, again, guys, there is something called, this is also autoimmune. You all might have heard, seniors, you all know this, right? APLS, antiphospholipid syndrome, right? This is also an autoimmune disorder. There is antibodies against cell surface phospholipids, right? So what is going to happen, guys? There can be vascular endothelial injury. When there is vascular endothelial injury, again, according to our Virchow's triad, right? There is going to be hypercoagulability, right? So because of that, how do you ask APLS in history if it is a female patient? You all can ask about recurrent miscarriages, right? Recurrent miscarriages, right? So if they say they have had a miscarriage, you have to ask how many miscarriages have you had, right? Within what duration of time, right? These kind of questions you have to just ask to exclude APLS, right? Unlikely at your MBBS level, you'll get an APLS case for medicine, but possible. Okay, possible. So just, you have to ask these questions, right? Even if you don't diagnose, now I don't like usually teaching just for exams, but what I want to tell you all is, for your exams, even if you don't 100% get the diagnosis, right? What the examiners want is for you to ask these. At least you have to ask these. At your undergraduate level, at least you have to ask the patient. Okay? Right? So don't miss asking these. Even if you don't 100% get the diagnosis, these kind of cases can be complex. Right? Okay. Let's move on. Any drug use, you have to ask about drug use. Cocaine, amphetamines, yesterday also we talked about, right? Females, guys, you all know combined oral contraceptive pills, COCP. COCP also has a risk associated with strokes. Okay? Risk associated with strokes, right? So boys, don't force your friends. Okay? Right? Okay. Right. Next. Hemorrhagic stroke, right? Hemorrhagic stroke, you have to ask a few questions, guys, right? Use of anticoagulants, you have to ask about, right? Especially if it was a previously diagnosed patient with a hemorrhagic stroke, they might be on anticoagulants, right? Guys, here you have to ask about history of head trauma. Why? in hemorrhagic stroke, we must ask about head trauma for obvious reasons, right? No need to tell you all that, no, right? That is a must. If there is a stroke patient, you must ask about head trauma. If you miss that, you all might lose the case, right? In your exam perspective and in the real life perspective, you might lose the patient. Okay. Must put this in red. If you don't ask this, big problem. Huh? Okay. So one of the first questions I asked my patient, now he said he lost consciousness. The first question, was there any bleeding from your head? Did you knock your head anywhere? First question. Okay. Always ask, right? And then you have to ask about any history of bleeding disorders, right? Right. You can, right, put all these questions. Then guys, this one is important. Ask about stroke-like or what we call stroke mimicking events, right? So there are these conditions where the patient can be appearing to have a stroke, although they are not, right? One of these are hypoglycemic attacks, right? You all know when the blood glucose drops, they can go into a comatose state. So they can have stroke-like, they can have sudden loss of consciousness. They can even have impairment of motor actions, right? These can be there, right? Any history of trauma, yes, we covered that already. Tumors. About tumors, guys, now you all know if there is a tumor, right? Like in that, the movie case that we discussed, there can be some manifestations that are similar to those of stroke, right? Depending on where the tumor is and compressing what structures. So you can ask about early morning headaches, vomiting. Yes, you can ask about behavioral change. Have you noticed? Because tumors are what, guys? Tumors are progressive. Tumors are progressive. So little by little, the patient actually notices those changes in his thinking patterns, in his behavior. The patient will notice. So you have to ask, right? Have you noticed any changes? Right? Then migraine, guys, there is a type of migraine called hemiplegic migraine, right? Okay. So this, no need to know for the undergraduate level, but just you all can know the name, what is happening, guys, with this migraine episode. Now you all know there are features, what we call the aura, right? With migraine, before the migraine sets in, there are certain features that the patient can sense that the migraine is going to come, the attack is going to come. So they are in this hemiplegic migraine, they get this hemiplegia type of symptoms coming in, right? Right? With the migraine coming in, right? So that is another question you have to ask about. Then guys, you have to ask about this thoughts paralysis, right? Again, this is about seizures, guys. Seizure coming in before the stroke, right? You have to ask about this because the seizure can be related to the stroke, right? No need to discuss this, right? It's a little bit advanced, right? Not necessary. Meningitis. Why should you ask about meningitis? Again, right? You know, they can have meningeal irritation features, right? So you can ask about fever, right? Altered behavior, neck stiffness, right? Projectile vomiting, these kind of things you can ask about, right? Okay. And then metabolic encephalopathy, right? And some, again, you asked about the recreational drug use, like we mentioned before, right? Right. Then guys, coming to the complications. Now you have to ask a few questions because of the stroke. What has happened to the patient, right? You have to ask about those also. Here guys, we ask about what we call pressure source or DVT. Now, if the patient has lost, right? If he's having hemiplegia, he'll be in bed most of the time, right? So there can be, when they're bedbound, they can have this pressure source, right? And when they're bedbound and not moving, what is the other is DVT, right? So you have to watch out for those, right? And then guys, depending on where the stroke has affected, they can have feeding failure, right? Specifically these oropharyngeal muscles, right? If they lose the function, right? So you will notice guys, these patients will be on an NG tube. When you go for your exams also, if the patient is on an NG tube, right? Or in your clinical practice, suspect, right? You all can now use in the homunculus where probably the lesion is, right? Okay, the face area, right? Right. Then again, right, associated seizures like our torticollis, right? You can ask a few questions, right? After the stroke, has the patient had any seizures, right? Very important to ask, right? Any cognitive functional decline, right? And any psychological related problems. This is what we talked about, the prefrontal cortex, right? Any behavioral issues, right? Here, guys, you have to also assess this. I sent this in the group as well. What we call this Barthel index, right? Okay. So I have here in my note, I attached it to the last page. You all can take a look at your notes as well, right? This one, there are 10 items in this Barthel index, guys. 10 items, right? Feeding, bathing, grooming, dressing, bowel, like that, right? Mobility. Here, what they do, we assess the patient, right? How much assistance the patient needs to carry out these basic activities. So what are we assessing by this, guys? What are we assessing by this? the patient's reduction in quality of life, right? Reduction in quality of life due to the stroke. Okay, right. Then you ask, guys, now the patient is presenting to you after coming to the hospital until you came and met the patient. What has been done? This is our current management, right? What has been done? Because if the patient has already been on thrombolytics, you don't want to start again on thrombolytics, right? Right? You have to know what to do and what to not do next, right? So you ask, what is one of the first things we want to do? Was the capillary blood sugar done? Was the NCCT, non-contrast CT scan done, right? Capillary blood sugar and NCCT, very important. You must ask, were these two done, right? Then you can ask, was the blood pressure checked? Blood pressure also must be checked, right? Because why? Hemorrhagic stroke, we said, very highly likely if it's hypertensive, right? Then you can ask, has any medication been started? Were you given aspirin? Aspirin, everyone knows, right? All the patients know what aspirin is, right? Were you given aspirin, right? Other medications, they might not know RTPA. No, just ask, were you given any medication, right? Then if it's a little bit of a chronic patient, right? Coming in for like maybe 1 or 2 week follow-up, you can ask, have you started physiotherapy? Have you started occupational therapy, right? Not in the acute setting, You don't ask these in the acute setting. If it's a follow-up patient, you can ask those questions, right? Right. Okay. Here, guys, with that, we'll segue a little bit with this current management, right, into our diagnostic part, right? So just write down a little. First thing is, guys, the NCCT, right? The NCCT. What is this NCCT and why are we doing this? This is a non-contrast. We don't give any contrast agent to the patient's blood, right? We just take a non-contrast CT. Why are we doing this non-contrast CT? Because we want to exclude, not to diagnose. We are doing this to exclude a hemorrhagic stroke. Exclude a hemorrhagic stroke, right? Hemorrhagic stroke, right? Okay, right? Because the management is completely the opposite. Right? Right. Then, guys, now if you're very good, sometimes, right? If you've done radiology, right? If you've done your master's and your PhD in radiology, sometimes you might be able to see ischemic features in a CT, right? Within the initial hours. But it is very, very, very rare and very, very, very difficult, right? Okay. If you're really good, sometimes you might see some hardening like a clot, right? A hyperdense in the vessel, but 99% of the time you will not, right? So what we see is, guys, initially when you do a NCCT in an ischemic stroke, right? I have put a picture for you all. Let's go a little bit to those diagrams. Yeah, there we go. Right? Right? 90% of the time, guys, this diagram, number 1, right? Number 1 here, right? What is this? This is a normal CT, right? This is a normal CT. There's a little bit of edema for the senior students, if you all notice, but it's okay, right? This is, for the most part, this is a normal CT. This is a normal CT. This is, guys, this is actually this is a real CT, right? Taken, right? 1 hour, within 1 hour after the onset of the stroke symptoms. Do we see anything? Nothing, right? Nothing. But what do we see? What is this second one? This is, guys, what we call a DWI, diffusion weighted MRI, right? It's a diffusion. This one, guys, now in Sri Lanka, not very available, right? Especially in the peripheries, we don't have this, right? We only have NCCT, right? So this is, you have to come more towards the city areas to find these, right? So this DWMRI, guys, very highly sensitive. Even they say within the first 20 to 30 minutes, this can capture ischemic stroke. This is an ischemic region, guys. This is an ischemic region seen in hyperintensity, right? Okay. Right. Then, look at this next one, guys. This is the same. This is another ischemic stroke, right? This is NCCT taken after the first 24 hours. Look at this. After the first 24 hours, guys, what can you see? You can see a slight discrimination of this affected area. Correct? You can see a slight area. And we see it, what, guys? Darker. What is this? We call it hypo-intensity, right? Hypo-intense area. Why do we now? The second one, guys, this is after the 4th day. Okay? This is after the 4th day. What do you see? Right? Very, very black, right? Why is this? Why are we getting a darker image in ischemic strokes? In the affected portions. Why do you think? Huh?
Production of hemoglobin.
Hemoglobin.
Oh.
Ischemia, like
Ischemia, yes. Why is ischemia appearing dark?
I'm not sure.
Right. Okay, let's take it step by step. Initially, we get ischemia. Then we get cell death. Then with cells dying, we get necrosis. Right?
Because
Right. So when there is necrosis, what is going to happen? There is going to be all these substances, right? The cells are starting to die, right? Inflammatory cells will start coming here, right? This area is going to lose tissue, right? Brain tissue is lost. When brain tissue is being lost, this starts appearing dark and dark and dark. This dark area, guys, you will see progressing, right? Progressing, right? Hypodensity, loss of brain substance, right? Okay. Then here I have put one more for you all, right? This one, don't worry, guys, right? Even if someone gives this to me, right? I'm not a neurologist now, right? Here, right? This right here, right? That's a lacuna stroke, right? It's a lacuna stroke. Okay. A lacuna stroke. Very tiny infarct, right? This is just next to the ventricle, right? If you all want to know, right, just know lacuna stroke have this predilection to the basal ganglia regions, right? They like to come near this basal ganglia, internal capsule type of regions, right? And if you take the brainstem, they like to come to the pons, right? Anyway, those are some, anyway, not very necessary. Just know, right? These are tiny lacuna stroke. Okay. Right. So we'll come back to our discussion. Where were we? Right. We stopped at the NCCT. So one of the very first things you must do for the patient is get a non-contrast CT scan. Right. Next. Right. Look at this, guys. Here, guys, there is another one that we can do. Again, not very commonly practiced in our countries. Right. There is something called a CTA, CT angiography. Now, if you all remember the ischemic heart disease, the students who came for the ischemic heart disease chapter, we also had an angiography there. What did we do, guys? We passed a finely guided catheter all the way up to the heart, right? All the way near the coronary artery, and we released a dye. Here, are we going to do the same thing? Are we going to put a catheter all the way up to the brain? No, right? No. We use the IV, right? Through the hand, we just give a IV dye. Right? That will go to the brain and then we do the imaging. Okay. This is how we do it. Right? We don't put a catheter all the way up to the brain. Right? So this CT angiography is done by injecting a dye using IV lines, usually in the hand. This can also be done, guys. We can look at the cerebral perfusion nicely, right? But it's quite expensive and uncommonly done. Right? In our setting, we stick to NCCT. Right? Okay. Apart from that, the DWI MRI is also there, diffusion weighted MRI. Again, not very commonly practiced. But diffusion weighted MRI, how does it work, guys? Do you all have any idea? Just by the name, what do you all think? Diffusion weighted. What do you all think? Diffusion weighted MRI, very interesting, guys. Diffusion weighted MRI, how it works is, it detects diffusion across membranes, diffusion of water molecules across membranes, right? It detects diffusion of water molecules across membranes. And wherever there is no diffusion, it will show in a hyperintensity. So in ischemic strokes, where is there no diffusion? At areas of cell death. When cells are dead, can diffusion occur? No. Right? So that is how a diffusion weighted MRI works. Right? Okay. Anyway, just some extra points for you all. Right? Then, those are the basic initial diagnostics that I want you all to know, guys. Right? Then we'll come again back to our history taking. Right? About the past medical history, you have to ask, were there any similar episodes in the past? Have you been given any medications, any anticoagulations, antiplatelets, right? Family history, you must ask about young onset strokes, right? Young onset strokes is very important, right? There is a family history. There are some conditions that run in families. These are thrombophilias, right? Right? Okay. Their blood has a very high tendency to clot, right? Right. So you have to ask young onset strokes, right? You can even ask about ischemic heart disease, right? Diabetes mellitus, hypertension. Yes, you must ask. And about the social history, guys, right? You have to start off with the family and the income because you all know these are debilitating conditions, right? Patient's quality of life drops. So now even the patient I had, he's a father of three girls, right? My patient was a father of three girls, still schooling age. So now this guy can't move an entire half of his body. So what is going to happen? He is the sole breadwinner of the family, right? Quality of life dropping, right? Not just for him, for his family. So you have to ask about the family. You have to ask about the income. How is the family support, right? Now, until the physiotherapy and occupational therapy can be done, is there anyone who can help you, right? These kind of questions you all must ask. Okay. You have to ask about the household environment, right? Is there any area where they can easily fall down, right? Right? Because these are further adding to the risk, right? Assess the family support, yes, social support, and nearest hospital and the rehabilitation centers, because after the stroke, you're going to send the patient to rehab, right? And he will be discouraged, right? If he's in a very rural area to come all the way to the center to do rehabilitation, he will be discouraged. He will not come. They will not spend the money and the time to come. Okay. So you have to ask about all of these guys, right? Distance to the washroom at home, right? Because the patient has to walk, right? All right. The Barthel index again, we can assess, right? These things you ask. Okay. That is about the basic history taking, right? Right. Then we'll come to the, next thing, guys, the examination, right? So when we are talking about the examination, what do we want to look in this patient? The first thing is the general examination, guys. We want to obviously make an assessment of the Glasgow Coma Scale, right? The Glasgow Coma score, right? You all know the full score is 15, right? If it is less than 8, we usually have to intubate the patient, right? Right? So very important to ask where to assess the GCS. Then you have to check if the patient is febrile, because we talked about infective endocarditis, right? One of a very major risk factor, right? And they can also have vasculitic, autoimmune, low-grade fevers, right? So you have to assess for these, right? Then guys, when you see the patient itself for infective endocarditis, what will the patients have? An IV cannula. So look for those as well, right? Then you can check for signs of any neck stiffness, because this is what we talked about, right? Specifically, meningitis, and even hemorrhagic type of strokes can have some meningeal irritation features, right? So you can check for that. Plethora in the case of what, guys? Polycythemia rubra vera, right? Excessive RBC production. So their entire face and all these areas appear reddish in appearance, right? That is another risk factor we discussed, right? And peripheral stigmata of hypercholesterolemia. These same stuff we have talked about for ischemic heart disease, guys, right? Right? So you can look for corneal arcus, right? Tendon xanthomas, xanthalismas, right? These kind of things you have to look for, right? And peripheral stigmata of infective endocarditis. Again, we have discussed this in the previous class, right? You're looking for all these features, right? Next, guys, neurological assessment. What are we going to do? Here, guys, you have to do a neurological examination bilaterally of the entire, not only his affected side. Let's say he's coming with left-sided weakness. No, you have to check bilaterally. You have to check both sides, right? Upper limb, lower limb, everything you have to check. And the cranial nerves also you must check. Okay. Full examination needs to be done. So what are we checking in the neurological examination, guys? We are checking for tone. Yesterday we talked about, right? Tone, power, reflexes, right? Babinski sign you have to look for, right? And you look for wasting and fasciculation. These are your basic things, right? And then, guys, you also have to check the fundoscopy. Now, today we talked about, right, if the ophthalmic artery is involved, right, there can be fundoscopic changes. Also, another thing, right, diabetes, right, you all know retinopathy. Retinopathy and diabetes is a high risk for stroke and stroke-related events, right? So you need to check the fundoscopy, right? Okay. Then, again, you have to check for gait abnormality. Yesterday, we talked about the classic hemiplegic gait, right? We talked about that, how it happens, and the circumduction, we talked about how it happens, right? So we have discussed those things, right? Then you must also do a cardiovascular examination, guys. Why? Because this is why I wanted to specifically do the stroke chapter after the ischemic heart disease. Very similar, guys. Pathophysiology, very similar, just the organ is different. End organ is different. So you must do a cardiovascular examination here. Why? We talked about embolic phenomena, specifically mitral stenosis. They can have atrial fibrillation we talked about, right? So you must do a CVS examination, look for palpitations, look for pulse, irregular pulse, right? Look for these kind of things. And you can look for now internal carotid artery. We talked about internal carotid artery can get occluded or obstructed, right? And then there can be thrombotic phenomena where the atherosclerotic plaque is in the internal carotid artery. When these changes happen in the internal carotid artery, guys, they can get what you call bruise. You can keep the step here and you can listen to bruise, right? The turbulence in the blood flow, right? So you can listen to these as well, right? Internal carotid artery bruise, right? Carotid artery bruise can be listened to, right? Okay. Now this carotid artery bruise, guys, right? Okay, it's okay, right? There's some extra things to say, but not very important, so I will leave it, right? Next thing, auscultate for mid-diastolic murmurs. Why? Right? Mitral stenosis, right? Okay, right. Don't worry about murmurs. I will do valvular heart disease, one of my favorite chapters. That's that is the first class I ever did in my life, guys. This is back in 2019. Valvular heart disease is how I started, right? Shashank, I think you were there, right? Excellent. Right. Okay. So I will do, what else are we going to do, guys? Respiratory system examination also we are going to do, because yesterday we talked about this respiratory failure, which can also be a risk factor for stroke, right? Because of the hypoxia, right? So you have to do a quick respiratory assessment. And the other thing is, guys, specifically we said the swallowing related muscles are going to be weak in some patients. So they might be on an NG tube. If that is the case, guys, there can be aspiration pneumonias and these kind of complications, right? So you must assess the respiratory system as well, right? Okay. Everyone clear up to this point, guys, right? Give me a thumbs up, right? All good, right? Let me see some more faces. Who is here? Imesh, all good, right? Excellent, excellent, right? Manari, all good? Yeah, Manari, which year? Which year from? Sorry, 1, 2, 3, 4, I can't hear. Final year. Okay, excellent, right? Good. Right, okay, let's continue. Now we come for the management plan, guys. Now, last week in ischemic heart disease, if you all remember, what did we say? It's an emergency, right? It's an emergency, right? When there was an emergency, what is the main thing, guys? Your diagnostics, your management, everything goes together. You don't take the history, you don't take the full history, waste the time there, and then go to the diagnostics, do all the testing, then go to the final, no, right? Everything goes hand in hand, right? Together. Everything goes together, right? This is the important point about emergency medicine, right? So when we get a patient coming in with symptoms of stroke, how do we approach him and how do we manage him? This is what we are going to talk about, right? Let's say, guys, we have a patient coming in, right? And let's say this is my patient. My patient, of course, came a little bit late. He came the next day, right? He came the next day, so it was kind of late. Let's say you all have a patient coming in within 2 hours, right? He's coming in within 2 hours. He's coming with let's say left-sided. Let's say he has a right-sided stroke. He's coming with left-sided face, arm, leg, weakness, and sensory loss, right? Now, he's coming within 1 hour, within 1 hour, right? Now, how are we going to approach this? Look at this, guys. The first thing, when there's a high degree of suspicion of stroke, we transfer the patient immediately to something called the stroke unit, right? We don't keep him in the normal ward, right? There is something called a stroke unit, especially in our setup in base hospitals and above, we have stroke units, right? Peripheral hospitals might not have, right? If there is not a stroke unit, use the acute side bed, it's okay, right? But it's better. There is a mortality benefit associated with the stroke unit, right? Okay, right. So you take the patient to the stroke unit, get him on the bed and check the airway, breathing, circulation, as with all our emergencies, right? Everyone knows this, right? Check the ABCs, right? If there is any problem there, you have to first correct that, right? And you connect the patient, as this says, to the cardiac monitor and the pulse oximeter. We want to look at the oxygen saturation and we want to look at his ECG, his heart function as well, right? Assess the GCS, right? If it is less than 8, we mentioned this before also, we have to intubate the patient. Okay, right? Then, guys, now you can take a quick history and examination, right? This needs to be very brief, guys. This history and examination total in the acute setting cannot take more than 10 minutes, maximum 10 minutes, right? Maximum 10 minutes from the time the patient arrives to you, the patient comes to you, right? Within 10 minutes, you must be done with the history and examination, right? So we've talked about the history, we've talked about the examination, what to do, right? So you do that, right? Then here, guys, when we put the patient to the bed, one more point to mention, we keep the head in the neutral position. What do we mean by this neutral position, guys? The body and the head are aligned, right? In one level. And if you look at the eyes are looking directly up, right? There is another position, guys, we use in some conditions called the sniff position. We keep a pillow under the neck. then the eyes will be pointing like this, obliquely, right? Okay, that's another different position. What we want is to keep the patient in neutral position. Keep the patient in the neutral position. Okay, keep the patient in the neutral position, right? Okay, and okay, what if you're another side point? If you all suspect that this is a hemorrhagic type of stroke, how should you all keep the patient? What do you all think? If there is a hemorrhagic type of stroke, guys, there can be what we call intracranial pressure elevation, right? ICP is going to elevate, right? If the ICP is elevating, intracranial pressure is elevating, we want to keep the patient slightly inclined on the bed. We want to lift the head end of the bed a little bit, right? To try and help to reduce the ICP, to try and help usually they say about 30 degrees, guys, about 30 degrees, right? That is if the ICP is high, right? If not really necessary, what we prefer is this, okay? In ischemic stroke, right? Okay. Then, right? So you do the initial quick history and the examination, right? You must do the capillary blood sugar. Capillary blood sugar. That is the first thing to check for, because even before the NCCT, guys, you have to check the CBS. Why? This is a stroke mimicking condition. And if you treat the hypoglycemic patient coming in with stroke-like symptoms, if you treat him with thrombolysis and treatment like a stroke, right? You're going to send him to heaven. Right? Okay, whatever you believe, right? Okay, so you must check the CBS before anything, right? So, and the important point here is, guys, it doesn't matter what the patient's sugar level is. We want to keep it the random blood sugar. The capillary blood sugar is, we are measuring a random. We don't ask the patient to fast for 2 hours and come, no, right? The patient is here in an emergency. You check randomly, you check the capillary blood. You quickly prick one of the fingertips and you take some blood and you check, right? We want to maintain a blood sugar of 140 to 180. Now, you all know when you consider random blood sugar, guys, right? In a normal person, we say around 110 to 140 is the normal range, right? Random blood sugar. Random, not fasting, random. Then if you take pre-diabetes, we say 140 to somewhere around 200 is pre-diabetes, right? And more than 200 is diabetes, right? So what are we doing? We are keeping the patient in this pre-diabetes type of range. Why, guys? Because there is going to be a lot of ischemia, right? And the patient's entire body is going into a state of stress, right? Therefore, we don't want to drop the blood glucose too much, because if we drop the blood glucose to these normal ranges, then the patient might crash and go towards hypoglycemia, and then we have to manage another emergency there. We have to manage a second hypoglycemic emergency there, right? So we don't want to do that. We don't want to risk that. So we are keeping this patient in around 140 to 180. Okay, clear? Right? Okay. Then the next thing, right? Where are we? Yes. Then the next thing is the NCCT. Yes, you must do the NCCT, right? We talked about that. Why are we doing the NCCT? To exclude hemorrhagic stroke. And this NCCT, after the patient arrives at the hospital entrance door, within 20 minutes, guys, we want the NCCT to be done, right? Now, history taking and examination within 10 minutes. NCCT, by the time we come to NCCT, we should be done within 20 minutes, okay? After entering the door of the hospital, okay? Then, yes, you must send blood for basic investigation, right? We want to look at the full blood counts, right? We want to look at the WBC, RBC counts. If you are suspecting polycythemia, we can check for that. Any infection like infective endocarditis, we can check for that, right? So you send the blood for basic investigation. And if facilities are available within the first 1 to 2 hours, you can do a diffusion weighted MRI, right? Okay. Right. So this is what happened to me. It's good to know for you all. But in my exam, so I said, so I had 2 male examiners. And I said, sir, I'm going to do a diffusion weighted MRI. They're like, what diffusion weighted mean? You don't have this facility here, right? What else are you going to do, right? Okay. So if they say like that, no problem. But you mention it, so you know something, right? It's okay. Just mention it, right? Okay. Then blood pressure. You have to check the blood pressure. We talked about this, right? Specifically, guys, if it is very high, one thing you must suspect hemorrhagic stroke. But now we have done the NCCT and we have excluded by this point that there is no hemorrhage, right? So if the blood pressure is still high, this can be the patient's own hypertension acting up, right? In this stressful situation, right? So therefore here we have to manage to reduce this blood pressure, guys, because there are some cutoffs we cannot exceed when it comes to our therapies, right? Specifically, guys, first thing I want you to remember, we'll talk about this later again. Here, just remember, firstly, we have to try and drop the blood pressure down to at least 185 by 110, right? At least drop it down to 185 by 110, right? And here, right, we have some drugs of choice, guys. Labetalol, right? Labetalol. Again, these are all we are giving IV. Yeah? No time for oral medication when you're doing an emergency management, right? So IV labetalol or IV, there's another one, nicardipine, right? Nicardipine. Okay. These drugs you can give to try and drop the blood pressure to at least 185 by 110. Okay. Right. Here, guys, there is another drug called hydralazine that also has a place, but not commonly used. Not commonly used. If you all are asked in the exam, can you use hydralazine? You can say, yes, we can use this, but not commonly done. We prefer to use labetalol and nicardipine. Okay, right. Then, what else? Then we come to the specific management of stroke. Now, this is very similar with some subtle differences from last week's class. Our ischemic heart disease, right? We talked about the management of acute, right? MIs, right? There we also talked about this thrombolysis. Here also, guys, our primary mainstay of management is thrombolysis, right? Thrombolysis. So for this thrombolysis, like in the last class, we are going to use RTPA, recombinant tissue plastinogen activator. But before we can start the patient on thrombolysis, we have to check if he has the indications. He should have the indications for you to start. What is these? What are these, guys? Right? Indication should be one thing. Patient should be more than 18 years of age. Right? More than 18 years of age. Right? Then there should be clinical diagnosis or what we call a measurable deficit of ischemic stroke. That means what the patient should clinically show the features of an ischemic stroke. Right? If not, it's not an indication to give thrombolysis. Right? In the case of stroke, so he should have like a spastic type of weakness. He should have sensory loss. He should have these features. Right? Okay. The next thing, guys, the patient must arrive at the hospital within 4.5 hours of the onset of the symptoms. Now, students who came for my last week's class, I'm going to catch you up, right? Last week in ischemic heart disease, in MIs, we talked about something called the door to balloon time, right? If you all remember. Anyone who joined last week's class, do you all remember? What was the door to balloon time? Prashan, unmute. Unmute.
I wasn't there, but the time.
Excellent. So you were there. Okay, good. 90 minutes. 90 minutes is the door to balloon time. Door to balloon time is 90 minutes. And what about the pain onset to arrival at the hospital time? In ischemic heart disease, pain onset to arrival at the hospital, 12 hours. 12 hours. Here in stroke, onset, we don't have a door to balloon time here, but we have onset of symptoms to arrival at the hospital, 4.5 hours. Okay, 4.5 hours. These subtle differences I want you all to, when you all are studying, guys, try to connect these chapters together. Okay, right? Okay, so these are the differences, right? Right. So those are the main indications. What are the contraindications, guys? Contraindications I've written here, right? You all can read, right? Minor or rapidly relieving symptoms, right? So because this can be your, especially if the patient comes and says, doctor, an hour ago I felt some weakness in my left arm. Now I'm fine, right? If they say, now what is that? Most likely transient ischemic attack, most likely, right? So if there is a transient ischemic attack, we don't want to thrombolyze the patient immediately, right? So because of that, those are contraindications, minor or rapidly resolving symptoms, right? Then head trauma within the last 3 months. This is very important. We said we have to always ask about the head trauma, right? Symptoms of ICH or SH, subarachnoid hemorrhage. You all know ICH, there is the pressure symptoms. So you all can get, there can be very severe headaches. SH is the thunderclap headache, right? Sudden severe onset of the headache, right? We'll talk about these in those relevant chapters also, right? Then guys, a reduction in platelet, right? Less than 100,000 or activated partial thrombus. Now these similar things are there in the ischemic heart disease also. Same stuff, right? APTT more than, APTT is elevated, right? So you have to look for these because these are contraindications for thrombolysis. Then arterial puncture within the last 7 days, again, because if a clot has formed at that arterial puncture site and now you're giving thrombolysis to break that clot, there can be arterial bleeds. And you all know arterial bleeds are a little bit difficult to control. Hemostasis is a little bit difficult, right? Because of the pressure, right? Then hypertension. This is why we said, guys, we want to reduce the blood pressure, right? If it is more than 185 or diastolic more than 100, it's a problem. So at least at the start, we want to start off with less than 185 by 110, right? 110, right? Then guys, we'll come to this specific management about RTA now, RTPA. Now, what are our management options, guys? One is the thrombolysis, our RTPA. And then there is something called mechanical thrombectomy also. We'll leave mechanical thrombectomy for a second, right? We'll talk about this thrombolysis a little bit. Firstly, by the time you're about to start RTPA, what must you have done? You must have excluded hemorrhagic stroke, right? If there is even a suspicion of hemorrhagic stroke, you will not start RTPA. Okay? You must exclude it. Otherwise, you're going to kill the patient. Okay? And then, guys, thrombolysis, we start, it's very easy to remember. Now, what was the onset of symptoms to arrival at the hospital? 4.5 hours. Thrombolysis, we usually want to start it by 45 minutes. So 4.5 hours and 45 minutes, right, of arrival at the hospital. Within about 45 minutes, we want to be starting RTPA. Okay, right? So if the patient came within 4.5 hours, our first choice is thrombolysis. If not, we can consider thrombectomy. I will talk about thrombectomy in a little bit, right? How do we give this thrombolysis? What is our drug of choice, guys? Altiplase, right? This is our drug of choice, altiplase, right? Altiplase, we give 0.9 milligram per kilogram, guys. There is a maximum of 90 milligram. We will not exceed this 90. Do not exceed 90 milligram, right? We give it 10%. The first 10%, we give it. So this is based on the patient weight, based on how many kilograms the patient is. 0.9 milligrams per every kilogram of the patient's body weight, right? First 10%, you give it as a bolus, right? Within 1 to 2 minutes. And the remainder, you give it as an infusion over 1 hour, right? As an infusion over 1 hour, right? Okay, right? Then, here there's a very important point, guys. If the patient was already on aspirin due to some other condition, if the patient was already on aspirin, you have to, for the time you're giving RTPA, you must discontinue, right? Aspirin. Yeah, you all can write down. I haven't written the rest. Since aspirin can cause, there is a risk, right, of causing hemorrhage, right? Aspirin and the RTPA together, when they get together, because you all know aspirin is antiplatelet, right? And RTPA, it's again activating plasmin that is going to come and break down the clots. So there is too much of clot breaking down activity if both are given together. So it can cause hemorrhage. There is a risk of hemorrhage, right? Okay. So we have to stop the aspirin, right, for the first 24 hours after giving our altiplase, right? For the first 24 hours that you're giving altiplase, you must stop aspirin, right? Okay. They actually say, guys, right, the actual guideline is 24 hours plus or minus 6 hours, right? We do another CT. After starting the patient on altiplase. And if the CT is normal, there is no evidence of hemorrhage, only then will we restart the patient on his aspirin. Okay? This is just some extra points for you all. Right? Now, if the patient had hypertension, what did we say? First, bring it down to less than 185 by 110. Right? After starting RTPA, guys, we want to maintain the blood pressure at less than 180 by 105. For the first 24 hours. Okay. Now these values, guys, for the emergency, you all know I am not an advocate at all of memorizing, but there are certain things we must as physicians, right? So these things, right? The management in the acute setting, you don't have time to go through guidelines and do all that. It must be here. Okay. These things must memorize. Okay. Right. Then, if RTPA is contraindicated, guys, we talked about the contraindications before, right? If RTPA is contraindicated, there are some other options. We can put the patient on aspirin 300 mg stat, right? Stat dose, right? And Atova for maybe 40 mg stat dose, right? These aspirin, guys, you will have to after that continue for about 2 weeks and then reassess the patient, right? There's a process there, but just remember, these are things that can come in your daily practice. If the patient is contraindicated for RTPA, what can you do? Right? Start the patient immediately on aspirin and Atova. Okay? Aspirin and Atova. Right? Okay. Then, guys, when do we consider this mechanical thrombectomy? Now, if the patient came within 4.5 hours, our first choice is thrombolysis, RTPA, right? If the patient arrived within 4.5 hours and the RTPA was done, but the RTPA failed, that is one indication to do thrombectomy. What is this thrombectomy, guys? We are basically putting a stent, right? Putting a finely guided wire all the way up to the affected area, and we are trying to break this thrombus. Right? They might even put a stent sometimes, depends on the procedure, right? There are some new instruments that they use, guys, right? There are some instruments where they go and drill into these thrombus areas, right? Very interesting, right? Anyway, we can do this mechanical thrombectomy, right? Another indication is, guys, if the patient came after 4.5 hours, but within 24 hours. Now, my specific patient that I was talking about before, he came within 24 hours, but definitely after 4.5, he came the next day. So he had the issue in the day 1 morning. He came towards the day 1 night. Right? Okay, so he had come within 24 hours, right? And I met the patient at the exam the next day, the day after that. Okay, right? So within 24 hours he had come, so he was in the window for thrombectomy, right? Right? And again, guys, you all can put a number 3 here. Actually, I think I've forgotten to put it. Another one is if it is a very large thrombus, very large thrombus, right? Even if the RTPA was successful, if the RTPA worked, still, even if it was a very large thrombus, we would, after the RTPA, want to do a mechanical thrombectomy to remove whatever, because it was a very large one, guys. Because you all know, when you all give thrombolysis, what is the chance? There is a chance of clots breaking down and growing and embolizing, right? So because of that, especially if it is a very large one, right? Even with successful RTPA, sometimes physicians and neurologists, right? They want to do a thrombectomy after the procedure. Okay, right? Is this clear up to this point? Right? All good? Right? Give me a thumbs up. Let me see some faces. I know today is a little bit heavy. Okay. These are tough topics, guys. If you all are able to stay like this without fainting, I'm very happy. Stroke is a bit of a tough topic, right? Not very easy, right? Now, valvular heart disease, very easy, right? Something like that, very easy. Stroke, a little bit complex. Right. Okay, good. Right. I'm happy. Right. Okay. Now, let's move on. Constant monitoring of the stable vitals. Guys, those are obvious things, no? You have to make sure you monitor the vitals, right? Right? I'm not even going to mention those, right? Let's move on. Now, what are some other investigations you can do after the initial supply? What do we mean by after the initial supplementation? Now, this is a medical emergency. So the patient came in the medical emergency. You initially went through some quick steps, right? Okay. After that initial stabilizing the patient, after starting the thrombolysis, after all of this that we discussed, now you can do some other investigation to further diagnose, to further look at some other complications, these kind of things, right? So those we are going to do next. What are these? Firstly, you draw blood for some other investigations. The lipid profile, you want to check the HbA1c, especially if it was a diabetic patient, right? These kind of things, right? Then since you all know the blood pressure, guys. Now, what did we say? If the patient came in with a high blood pressure, now you're also giving some management to drop the blood pressure to 185, right? Then 180, right? Like that. So when you're doing these active managements, there is a chance the blood pressure can crash because you're aggressively managing these things, right? There is a chance the blood pressure can crash. So you must, especially for the first few days with all these medications going on, you must regularly check his BP and the vitals to make sure his blood pressure is not crashing. Okay. Right. Especially within the first few days, right? Okay. You want to prevent hypotension. The next thing, arrange for these Doppler studies. What are these Doppler studies, guys? It's basically our ultrasound. Doppler is our ultrasound, right? Here, there are some specific ultrasounds, guys, that we like to do, right? One is called carotid artery Doppler. Carotid artery Doppler, right? Carotid artery Doppler. What is this carotid artery Doppler, guys? What strokes are we looking for in the carotid artery Doppler? Answer me. Unmute. Let's stop. What strokes are we looking for? Carotid artery Doppler. Which circulation are we looking for? Which circulation strokes?
Posterior.
Internal carotid artery, posterior. Remember the anterior and the posterior circulation? Anterior circulation. Okay, anterior circulation. Yesterday's class, we talked about why they are called the anterior circulation and why they are called the posterior circulation, right? Because in the neck, if you all remember, the carotids, they were more anterior. right? Okay. And the branches they give are also anterior, right? Okay. So in the carotid artery Doppler, we are looking for anterior circulation strokes, right? Okay. The other one you mentioned is for the next, okay? The one you mentioned is for the next transcortical, right? This transcortical Doppler. There's another one called transcortical Doppler, guys. This is what we do to look at the vertebrobasilar system, right? We can look at the circle of Willis, right? The vertebral artery, the basilar artery. And that means here we are looking for the posterior circulation stuff. Okay. Carotid artery Doppler is for anterior circulation strokes. Okay. So we can arrange for these type of Dopplers. Then guys, a 2D echo. Why are we doing a 2D echo in a patient who has had a 2D echo of the chest, 2D echo of the heart? Why are we doing a 2D echo of the heart for a patient? Echocardiogram, no guys, it's a cardiography, right? Why are we doing the echocardiogram in a patient who is having a stroke? You have studied. Come on, tell me.
Check the
Valvular heart
Mitral
disease.
stenosis.
AF.
Excellent, right? Valvular heart disease, mitral stenosis, AF, right? That's it, right? Nothing complex here. And one more, infective endocarditis vegetations, right? That also we can check. And if they have had a MI, what can we check for in the echo? Last week, who came for my class? If there is an MI in the echocardiogram, what are we looking for? What is the word? Huh? Who came last week? Let me check. Shiza is here.
Hibernating myocardium.
Sorry? I didn't hear you.
Something like a hibernating myocardium or something.
Hibernating is not the word. Hypokinesia of the myocardium. Okay, right? Yeah, but close enough. You have the idea. Okay, that's good. Right? Hypokinesia. You're going to look right. Okay. Then, what else? Diagnosis and management of any other underlying risk factors are complicated. This is what we talked about, guys. If the patient is having diabetes, you have to manage that. If he's having hypertension, you have to manage that. If the patient is having arrhythmias, like we said, because of the valvular heart disease, right? They can have atrial fibrillation. So you must do 24-hour Holter monitoring, right? You have to check the ECGs, right? You have to look for all of these, right? We will have my final class for this series will be about ECG, how to understand ECGs, right? So we'll talk about those there as well. Then suspicion of polycythemia, right? Again, right? Polycythemia, guys, you all can look for the ABG. The important thing is I want you all to look for the blood picture, right? First check the blood picture. You all can check the ABG and the oxygen saturation as well, right? Apart this hepatomegaly, guys, right? There can be some hepatomegaly due to when there is just think of this, there are too much of RBCs being produced. And when too much of RBC is being produced in polycythemia, these RBCs are not very, efficient in oxygen carrying capacity, right? They are not very efficient. There is a lot of red blood cells, but functionality wise, they are not very efficient. So what is going to happen in the liver, right? And in the spleen, they are going to be broken down, right? These ineffective erythropoietic cells, they can be broken down. So we can see some hepatomegaly. So you can do an ultrasound scan abdomen, right? Okay. For that. Then yes, again, screen for thrombophilias, APLS, you can do autoimmune studies, right? Paroxysmal nocturnal hemoglobinuria is another condition that can come along with glomerulonephritis, right? We'll not talk about these in too much of depth, right? Okay, not very important, guys, right? Right. Then, next, long-term management. Now you have managed the acute setting, right? You have managed the acute setting, patient is stable. Now, before discharging the patient, how are you going to manage this patient in the long term, right? This is what we're going to talk about. So for minor strokes, guys, we can start the patient, or even before starting these medications, what should you first advise the patient on? This? For strokes, and even last week we talked about for these ischemic events, right? What are you going to talk about? Come on. Right, last bit.
Lifestyle modifications.
Excellent. Lifestyle modification. You identify the risk factors that the patient is having. If he's smoking, you have to ask to stop, right? Alcohol consumption, heavy alcohol consumption, ask to stop, right? So you have to go in a stepwise approach, guys. You can't suddenly ask to stop. No one will stop, right? So you have to arrange for sessions, right? There is these nicotine patches, these kind of medications, right? You can do, right? So specifically for these thrombotic causes, guys, we want to put the patient on antiplatelets. That is our aspirin and our clopidogrel. Last week's class, we talked about how clopidogrel works, right? It's a glycoprotein 2B3A activator, and we talked about aspirin as well, COX inhibition, right? Guys, if anyone missed that class, it's on YouTube. It's on YouTube. Go and check it out, right? We talked about a lot of these same basic concepts there. That's why I'm not repeating the same stuff again, right? And atorvastatin, yes, for dyslipidemia, right? Dyslipidemia control, right? Lifestyle and risk factor management. Yes, what we mentioned, hypertension, right? Blood sugar control, all of these same stuff. Here, guys, this is important, right? Early mobilization is key in strokes, right? Because you must put the patient immediately for physiotherapy and occupational therapy, because otherwise their quality of life will drastically decline, right? Quality of life drops, because they can form all this tightening of these tendons, right? And muscles can go into wasting and fasciculation. Yesterday, we talked about something about disuse atrophy, right? Disuse atrophy can be there. Yesterday, we mentioned, right? So because of that, we have to do this early mobilization physiotherapy, right? To get the patient's power and tone back, right? Power and tone back, right? Then guys, here, one more thing you all can write on the side. So those managements initially with the aspirin, clopidogrel, atorvastatin, right? We do this for almost all the patients, guys. We'll do this for almost all patients coming in with a stroke for their, as their discharge medications. However, if this patient was diagnosed of stroke due to an embolic cause, what do we say our embolic causes? Like our mitral stenosis, infective endocarditis, right? Mechanical heart valves. Yesterday we talked about. If our patient was diagnosed of a stroke due to these conditions, right? Here, we have to also anticoagulate the patient, coagulate the patient, right? So here, our drugs of choice, guys, we have warfarin, right? We might have to put, especially if the patient has been having mitral stenosis, we have to put them on warfarin to prevent future attacks, right? Warfarin. And then now, I don't know if you all have heard, guys, there is this DOAC, right? Directly acting, right? Oral anticoagulants, right? Okay, right? Direct acting oral anticoagulants, right? Right? Here, what are our choices, guys? We have apixaban, right? Then there is another one, rivaroxaban, right? And there's another one, dabigatran, right? Seniors, you all must know these. Juniors, it's okay. You all have time, right? Don't worry, right? Apixaban, rivaroxaban, guys, what are these? Seniors, what are these? These are factor 10 inhibitors, right? Factor 10 inhibitors. Okay. This dabigatran is what? This is a thrombin inhibitor. Right? Thrombin inhibitor. Okay. Thrombin inhibitor. Right. Okay. Right. So these are our main management options. Then guys, I have put some additional points for you all, right? These are what you should know in your clinical practice, right? Especially 4th, 5th intern year students, and right, if you all are working in the hospital setting, you all must know, right? One thing is complications with the use of altiplase. Now you all know this is what recombinant tissue plasminogen is. So it's going to activate plasmin, what we call plasmin. Plasmin come and breaks down clots, right? Specifically, it's very specific to fibrin, right? It's very specific to fibrin. So what it comes and does, when it breaks clots like this, guys, there is a tendency of bleeding. The patient can start bleeding now. You're trying to break the clots to prevent the ischemia. But now what is going to happen? The patient is going to start bleeding. So if there is any evidence of bleeding, this is why we need to do a CT even after 24 hours of starting the medications, right? Usually within 12 hours, we will do one, and after 24 hours, we will do another one, right? To look for any evidence of hemorrhage, right? So here, if there is any evidence of hemorrhage, stop the altiplase immediately. You have to quickly check the ABCs, right? Vitals, capillary blood sugar, these things same, right? Mean arterial pressure. You can also check the ICP, guys. You must also check the ICP if the fellow is bleeding, right? Okay, right? And then you take blood for full blood count, PTINR. Yes, you can do this. You can do a clotting profile, right? And we have to type and cross match and keep some blood ready, right? Because if he starts going into hemorrhagic shock, we have to manage that emergency as well. That's another medical emergency, right? Urgent NCCT, yes, to confirm if there is hemorrhage, right? You must do. Okay, right? Right, then, here guys, you can also get this cryoprecipitate, right? This has a lot of factor 8. And there is this newer drug called tranexamic acid. It's not actually very new, but to our local setup here, it's quite new, and we don't find this a lot in our peripheries. Okay, in Sri Lanka, right? But yeah, we can use tranexamic acid as well, right? And immediately, as soon as possible, if there is hemorrhage, neurosurgery consultation, right? We have to decompress, right? Okay, if there is a large hematoma, we might need to decompress and take it out, right? Take it out. Okay, clear. Then guys, a few points about how you will manage a hemorrhagic stroke, right? This one is not a high yield area for your MBBS level, but what you should need to know firstly, what did we say? Hemorrhagic stroke, suspect if there is hypertension, right? And because of that, actively manage to reduce the blood pressure, right? Okay, you must reduce the blood pressure, right? Assess the ABC, stabilize the patient, right? Again, the stroke unit comes here, right? We want to transfer them to the stroke unit, right? Look for features of deteriorating consciousness. What are we going to look for? GCS. Look for the GCS, right? That is an indication of a large hemorrhage. And if GCS is dropping, especially if it is less than 8, we need to intubate. Then you say, I will call for neurosurgical consultation, right? As soon as possible. Okay. Right. Then guys, a few more points. How will you manage this? This is another extra point. Transient ischemic attack. How will you manage that? Again, what do we do, guys? A patient comes in complaining, doctor, today morning I woke up, right? My left hand and left leg was weak. I couldn't move at all. Then after a while, it was fine. And now I was able to nicely walk and come to the hospital. What is your suspicion? Transient ischemic attack. If you're suspecting a transient ischemic attack still, although it is transient, although it is temporary, what is the risk? There can be multiple transient ischemic attacks happening in that one local region. Therefore, you must do a NCCT or a diffusion weighted MRI if available, right? You must, even in transient ischemic attacks, you must do a NCCT, right? To try and exclude hemorrhage first, right? How do we manage, guys? Again, here, when we are talking about the management, guys, I have put the specific management here, but even before that, there is something called the risk stratification that we must do for transient ischemic attack. What are we looking from this risk stratification in a patient coming with transient ischemic attacks? Now try to think about it. Patient is coming with a transient, temporary loss of neuromotor function. So there can be a motor or sensory effect, whatever, temporary. 1 hour ago, 2 hours ago. What are we doing from this risk stratification, guys? What are we looking for? What do you all think? Come on, just unmute and just talk with me. Right? Risk stratification. What are we looking for in the patient with a TIA?
For further episodes, that could. I mean, the contents of the stratification.
No. Okay, what is our idea behind doing what we call a risk stratification? What risk are we assessing here?
Whether it's like appropriate to give the risk between the bleeding tendency and the whether the patient really require the anticoagulation or not. Not the anticoagulation.
Right. Good. So y'all are thinking. What we are exactly assessing now, based on our pathophysiology, guys, remember we talked about, if we look at transient ischemic attacks, these are tiny ones. But what did we say the risk was? There can be multiple, right? That eventually gives rise to a full neurological deficit, right? Just like a stroke. So what we are doing with this risk stratification, guys, we are looking for the risk of a subsequent stroke, full stroke. This is what we are looking for. What is the risk this patient has, the patient who came in with a TIA, of him developing a full stroke, right? This is what we want to look for, right? So for that, there is a scoring system, guys, right? Now here, what are we looking for? This ABCD scoring system. Look at this, guys. A, age, more than 60, greater than or equals to 60. We give them a score, right? 1 point. Okay. Then there is B, blood pressure. Blood pressure, we check if it is more than 140 by 90. Right? If it is more than 140 by 90, again, 1 point, right? Then we have C, right? What is this? Clinical deficit. That means what we see clinically. Clinically deficit. Here, guys, it's very specific to the scoring system. These, they are found from research. Okay? Clinical deficit, if it is only aphasia, only aphasia, the patient gets 1 point. 1 point. Okay. Right? If he's having aphasia plus any other neurological deficit, sensory, motor, whatever, any other neurological deficit, he gets a score of 2 there. He gets a score of 2. Right? That is C. Then D, guys, we have 2 Ds, right? One is duration, right? The onset of the symptoms has lasted, the symptoms have lasted. If it is less than 1 hour, he gets 1 point, right? And if it is greater than or equals to 1 hour, right, he gets 2 points. 2 points. Right? And there is one more D, diabetes. If the patient is positive for diabetes, it doesn't matter type 1 or type 2. If the patient has diabetes, he gets 1 point. He gets 1 point. Right? So out of this scoring system, guys, what are we doing? If the total score is less than 3, there is a very low risk that this patient will have a subsequent stroke. Right? Very low risk. Right? Then, if it is between 4 to 5, if the score is between 4 to 5, there is a mild or moderate risk. And as you all can imagine, if it is greater than or equal to 6, it is a very high risk patient. So if that is the case, if it is high risk, what should we do, guys? Do we start RTPA immediately? No. Right? A TIA is not an indication for an RTPA. Okay? We need some other features as well. Just because the patient has a TIA, we can't start them on RTPA. But what should we do? We should not discharge the patient. This is the important point. Don't send the patient home, right? You must observe the patient, right? If he is in moderate to high risk, we do not discharge the patient. Okay, right? Low risk, it's okay. We can start the medication, right? There is a specific set of medications for TIA. Again, we put the patient on aspirin 300 mg stat, right? We send them to neurosurgery consultation, medical, not neurosurgery, internal medicine, neurology consultation, right? And you can do a carotid artery Doppler also, right? Because we want to look for the carotid artery, the anterior circulation and the carotid artery, because remember, right, transient ischemic attacks can present with the carotid artery involvement as pure motor or pure sensory we talked about. Okay, right? And there is a place for what we call endarterectomy. What is this endarterectomy, guys? Let's say this is the vessel, right? This is the carotid vessel, and this was the plaque. Let's say this was the plaque, right? The atherosclerotic plaque. What is this endarterectomy, guys? We put a wire like this, right? And we guide that wire all the way past, right? We put that guide wire all the way past our lesion, or what we call the atherosclerotic plaque, right? And then it can expand a small balloon and we pull it out. So this fat lobule will be moving out along with that and be taken out. Okay. That is endarterectomy, guys, right? Not very necessary at this level, but we have to understand about transient ischemic attack risk stratification. Okay, right? Is everyone clear about this? About strokes, right? Let me stop the share, look at your faces, see how many have collapsed. No problem. Right? Right? How are you guys? Understood stroke? This is everything you need for stroke for your MBBS level. Nothing more than this will be asked. Nothing more than this can come. And in your clinical practice also, this is enough for 95% of everything stroke related. Okay. Right? Okay. Those who are working in hospitals, you all must be knowing, right? This knowledge is enough. This knowledge is enough if you all can diagnose. Right? All good. Give me a thumbs up. Right? Just show me your faces. Right? Right? How are you all? Taimur, all good, all clear, right? Okay. Right. Lula, all good, all clear? Yeah? Right. Okay. So that's about it for today's session, guys. When is our next session, guys? Let me check our timetable. I think next week, right? Take a look. Yeah. So we'll have the next session on thalassemia, right? On 10th of October, very, very high yield topic in pediatrics, guys, right? So we will talk about the mechanisms and everything there, right? I will teach you all A to Z, don't worry, right? And that's only one session. It's not a heavy session like this, right? That's why I put them in one session, both the clinical core concepts and the clinical skills together, right? CC and CS together. Then we have again on 11th and 14th, right? And 15th will be your bonus session. So I will see you guys again on the 10th, right? yeah, that's about it, guys, from stroke. If you all have any question now, yesterday actually very good. I got 2 questions regarding the stroke chapter that we discussed yesterday. Very good, excellent. If you all have any questions, anytime, even 2 a.m. in the morning, doesn't matter. I will wake up. I will be after 2 a.m. Right? I will wake up. I wake up by 4:35. Right? I will message you. Right? If any question, just drop me a message. Right? And if you all have any feedback again, right? By all means, message me. Right? Let me know if there is anything I can improve on. Right? That's about it, guys. I will see you guys in the next session. Right? Take care. Right? You're welcome. You're welcome.